I'm happy to be here with you today. We're going to start the lung cancer module. We have several international and international speakers who are experts in lung cancer. As you know, we have many more drugs available, systemic treatments for patients who have an actionable mutation and for those who unfortunately don't, who can be susceptible to treatment with immunotherapy. And we know of the great advances or the progress that has been made in the immunotherapy and radiotherapy. So we're going to start this program with combination of radiotherapy and monotherapy, advances and perspectives by Dr. Adolfo Fernandez. Dr. Fernandez is a specialist in radiotherapy. He graduated from the Centro Médico Nacional Siglo XXI. He is an attending there where he is in charge of the chest department. He's professor of radio-oncology and he is a great friend of mine. So, Dr. Fernandez.
Hola, buen día tengan todos. Es para mí un gusto estar aquí el día de hoy. Agradezco la invitación al comité organizador.
Thank you to the organizing committee of SMEO. My name is Adolfo Fernandez. I'm a radiologist, oncologist. I'm going to talk about the combination of radiotherapy and immunotherapy. So before I start, I want to talk about key issues to remember, to talk about the synergy of the combination of these two drugs or these two treatments. The effect of radiotherapy is direct and indirect. The direct refers to the radiation beam directly on the DNA strand, breaking it, and indirectly when radiation interacts with water molecules of tumor tissue with the production of free radicals after this process. These free radicals affect the DNA strand. And the cells involved in the recognition and rejection of tumors, we have three main groups, the ones in charge of recognizing what is the foreign things and destroying it. We have CD4, CD8, and NKs. We have the counterpart that inhibits the response. So we have T-regulating lymphocytes and myeloid cells. There are other cells that are antigen presenting. We have macrophages and dendritic cells. And very importantly, the presence of T cells and the major histocompatibility complex also are present to activate the immune system. So naturally, in an optimal state, the immune system will recognize tumor cells and destroy them before they start creating tumors. However, these tumor cells tend to develop certain characteristics that combine with the potential to evade that response. That is called immune escape, related to these mechanisms, the presence of the increase of ligands and reduction of the MHC1 expression and the increase in the number of myeloid cells. How does radiotherapy work then in the immune system? We know that radiotherapy unmasks, so to speak, unmasks the tumor. It has mechanisms in favor of tumor control and others against it, as I will show you. Initially, radiation increases the visibility of tumor antigens because damage to the DNA strand of the tumor cells creates neoantigens. These are particles that would not be available to be identified but unless the radiation had an effect. So these antigens are in the extra tumor environment, and that's where they can be recognized. So radiation will also increase the recruitment of dendritic cells where those neoantigens are and the damaged tumor cells. And radiotherapy increases the expression of the MHC1. As I said, this MHC1 with the T receptors, they bind to these T cells. It will also activate the different gene pathways that give way to, or that make the immune response increase. For example, we have cycloferin stimulating cells. Part of the antigens secondary to radiation, we have the cyclic GMPs and AMPs that increase the transcription of interferon type 1. This type 1 interferon is related to viral infections. It's one of the first mechanisms of defense. But we know it has anti-proliferative effects and pro-apoptotic. So it is a very important pathway. It plays a very important role in the anti-cancer immunity. These two mechanisms are in favor, or rather destroy tumor cells. But with radiation, not everything is as good as it sounds, because it also gives way to certain mechanisms that go against this immune response. For example, after the administration of radiation, there's recruitment of myeloid cells, as I said, and these cells block the anti-tumor response. And there's also recruitment of T-regulating cells and macrophages that inhibit the activation of cytotoxic cells, activating the production of TGF-beta and also T and NK cells, and therefore dendritic cells do not mature. So although it seems that it doesn't control cancer, the truth is that it is a control mechanism of the immune system. So once all these actions are activated, the organism has to find a way to moderate the response. But this is how the mechanisms where tumor cells take advantage of this in order to achieve that immune escape. So with these mechanisms, with a local effect of radiation, this mechanism is divided into two, in favor and against the tumor control. So these are the same, but divided into in favor and against. In favor would be the alteration or of the tumor immunogenicity and the generation of pro-inflammatory cytokines. So their tumor cells get to the tumor, and the MHC expression is increased. And radiation can also express PD-L1 and increase the presence of TGF-beta. And in general, this gives way to immunosuppression of T cells. This is the process step by step. So the tumor is radiated. There's production of antigens secondary to the DNA damage. There's also recruitment of antigen-presenting cells, and these cells take these new antigens, and they travel through lymph nodes to the lymph. This is the site where they bind to cytotoxic T lymphocytes. So it's important, once again, the MHC in the T receptor. Now that lymphocyte can recognize the particular antigen and attack it. These activated lymphocytes travel to the site of the tumor, detect it, and destroy it. So in general, this is the scenario of how the immune system interacts, favored or supported by the effect of radiation. But not everything stops there, because those activated lymphocytes can travel to the blood capillaries and get to the systemic circulation. And that's where we see the Abscopal effect. The Abscopal effect means the systemic effects of administering local radiotherapy. This effect has been known for many years. There are cases where that happened, that radiation was applied in a metastatic site, and if there was a response in another site that did not receive treatment. In this slide, I'm showing the publications about the Abscopal effect in non-small cell lung cancer. And as of 2010, there's great interest in researching this. So at the time, it's when we think that the combination of immunotherapy and radiotherapy can favor these effects. So although we know the mechanism of action of how all this works, the global incidence of the effect is low. So this can be translated into complex mechanisms in favor and against tumor control. In such a way that when we give patient treatment, what we want is to take advantage of each effect. And we want the effect of all this to synergize. Let's see the translation of all these effects in real life. What has been reported in the literature? I'm going to show you, for example, that this immuno-RT combination was initially studied in metastatic disease. This is a trial. This is a keynote 001. This was a phase 1 trial evaluating the effect of radiotherapy and pembrolizumab. These were patients with non-small cell lung cancer. They were given treatment with a conventional treatment. The median follow-up was 35 months, and the result was that there was an improvement in survival, both global as well as progression-free, favoring the combination arm of those treatments. This trial also assesses the combination, but unlike the previous one, the treatment was SBRT and also patients with metastatic lung cancer, evaluating pembrolizumab with or without SBRT, 24 grays and 3 fractions, and they assessed the global response rate. At 12 weeks, there was an improvement of 18 versus 36% in favor of the combination with SBRT. So what happens knowing the mechanism of action of these treatments and the combination of metastatic disease? So we would have to investigate what happens if I want to transpolate all of this, to locally advanced metastatic disease. And this is a Pacific trial that evaluated durvalumab in lung cancer, stage 3, non-resectable, and concomitant chemo and radiotherapy with no progression after 2 cycles of treatment. It was divided into 2 arms, given durvalumab or placebo in the first 42 days of finishing the concomitants. And the outcome was progression-free survival and overall survival. And the results were that with a median follow-up of 14.5 months, there was a progression-free survival of 10.8 versus 5.6 months. That was statistically significant. It reported other secondary results, but the primary endpoints, which was overall survival, there was an improvement in the survival when the immuno-RT combination was used. So the use of durvalumab after chemo-RT is category 1 in the international guidelines. And this is like taking another step in the treatment of these patients, because like in medical oncology, There are new molecules available, more and more for cancer treatment. In radiotherapy, we've made great progress in the techniques of how to apply a treatment. For example, modulated intensity, BMAT, protons, etc., in order to improve the outcome of the patients. And nevertheless, for many years, the progress was only decreased toxicity, and this didn't translate into survival benefits. And it's not until this combination, immunotherapy and radiotherapy, we have seen survival benefits. So as I said, it's like taking a step further. This is something we can offer to our patients now. This is these are current trials to assess this combination. And finally, this is what I think are the challenges we have to face to continue to investigate this treatment combination. And first of all, the radiotherapy dose. We've used a conventional fractioning, 2.5 grays per fraction, 5 days a week, specifically in lung cancer, and the dose is 60 grays. We've used normal fractioning and the repair of the DNA and the healthy tissue, and this regulates the cell cycle of tumor cells. However, the trend is to look at altered fractioning. There's very little action the higher the dose, and the evidence is that these high doses trigger better synergy with a combination of immunotherapy and radiotherapy. This is what we're still investigating, to look at the optimal hypofractioning dose, but there's nothing definitive yet. Another, and we can give it to concomitantly, an induction or consolidation. Each approach has different advantages. We would look for disease control early, or concomitantly. We want to increase the effects of the synergy in both modalities, and as consolidation and activation of the immune response long term. However, there isn't evidence yet that tells us that the one approach of these sequence is better than the other or another. These are the trials, as you can see, as we are seeing or different molecules to investigate the effect. They're also evaluating different treatment sequences. So this is another area of opportunity. Another challenge is if it's possible to minimize the effect of radiation in T cells. As we saw, the success of immunotherapy depends on the good operation of T cells, and the radiation has a negative effect in T cells when we give treatment, as the T cells that go into the peripheral areas when the radiation is given. And the activation of T cells takes place in lymph nodes. And many times we include these regions in the volume to treat, because of the tumor we are treating. We know tumor control is not effective when we treat lymph nodes, but with everything we're seeing, I think it's something that is worthwhile evaluating. And the fact that we also assess the toxicity of the combined treatments. We know that the use of immune oncology treatments. What I think is worthwhile is to look at the combination of immuno-RT, but not from a perspective of cytotoxicity, but as an immunomodulator. Here, the toxicity pattern of radiotherapy is predictable, and we already know a lot about radiation, about the restrictions to risk organs in terms of doses and volumes and tolerance. So rarely the combination I mean, radiation doesn't mean more toxicity than.
Me parece importante mencionar esto. Me parece importante mencionar que que el progreso de la combinación de la inmunoradioterapia depende de mejorar el entendimiento de las vías de sinergia de la combinación. Con esto podríamos analizar las vías de respuesta o de resistencia de la terapéutica. Y también muy importante, pienso que sería esto, llevar a cabo un cambio de paradigma respecto a la forma en cómo se administra la radioterapia. Es decir, abrir la mente, no cerrarse, como cuando se empezó a investigar el efecto de hipofraccionamientos, por decir un ejemplo, ¿no? El tratamiento convencional era el estándar, pero se cambió el paradigma y el hipofraccionamiento en la actualidad es estándar también ya en muchos tipos de cáncer. Entonces, algo como eso es lo que se necesita para que se permita que la combinación de estos tratamientos se traduzcan en mejorías objetivas en estos pacientes. Pues no me queda más que reiterar mi agradecimiento a la Sociedad Mexicana de Oncología por esta oportunidad que me dan de poder platicar con ustedes el día de hoy. Y a todos ustedes, invitarlos a lo que mencioné en la última diapositiva, que es abrir nuestras mentes y ponerlas a trabajar para conseguir cosas mejores. Muchas gracias.
Les presento al doctor Santiago Ponce. El doctor Santiago Ponce es especialista en oncología médica, es experto en medicina de precisión e inmunoterapia. Con anterioridad ha sido jefe de la unidad de cáncer de pulmón del Servicio de Oncología Médica del Hospital Universitario 12 de octubre de Madrid. Actualmente el doctor se encuentra en el Departamento de Innovación Terapéutica y Ensayos Tempranos en el Instituto Gustave Roussy. Y pues muchas gracias, doctor, por acompañarnos el día de hoy. Vamos a escuchar el tema nuevos blancos terapéuticos e inhibidores de tirosincinasa. Gracias, doctor Ponce.
Aquí. 15 minutos. Bueno, muchas gracias por la invitación a la SMEO, ¿no? La verdad que es un placer estar aquí en México, ¿no? Que siento como mi casa y sobre todo por salir de Europa, que también esto está muy bien, dado que es el primer congreso presencial al que voy fuera de Europa y por esto, bueno, reitero mi agradecimiento de estar aquí. En los siguientes 30 minutos vamos a tratar de desbrozar, hacer una visión general sobre todo las necesidades, de las novedades que hemos tenido en este último año respecto a terapias dirigidas en cáncer de pulmón y brevemente quizá vamos a hacer un pequeño apunte a algo que en esta enfermedad que nos gusta, que es el cáncer de pulmón, ha supuesto la verdadera revolución de la medicina de precisión, con algunos factores o claves que creo que hay que tener en cuenta a la hora de afrontar esta enfermedad, ¿no? Estos son mis disclosures y a ver si va aquí. Yo creo que hay que tener muy en cuenta
to bear in mind that when we talk about lung cancer, we knew that obviously non-small cell cancers and big cell cancers were different with different behaviors, with different prognosis. As part of the first evolution towards precision medicine in lung cancer, which was histology, we already had different drugs for each histology, and these showed future for patients and how we would treat them with anti-angiogenic or not, with methotrexate, maintenance therapy or not. This is where we started to do precision medicine for lung cancer. Obviously, this box of histology, we have divided it into small boxes with molecular studies. At the beginning, we thought that perhaps many of them were static, but we know that these small molecular cases that we have may be present from the beginning, some of them, or perhaps what's more complex still is that they can be intertwined as resistances appear within these groups or subgroups. Therefore, we don't have one disease, we have several diseases. Therefore, we need to treat them as many diseases, and we need to diagnose them as well. And perhaps this is the most challenging at this point in time. Why? And this is because of what the orthodox people of methodology say. At the end of the day, what drives me and what drives all of you is that patients should live longer. If we have better diagnosis of patients and if we give better drugs to patients from the very beginning, obviously we will have an impact on their overall survival. And also we will be able to improve their quality of life because therapies will be better and will be less toxic. So this takes us to the concept we discussed at the beginning. This is precision medicine. Historically, in oncology, we have used therapies such as radiation therapy, chemotherapy, also some hormone therapy, without really breaking down much this into the different patients and subgroup of patients that we have within that huge population. And due to that, we have also conducted some clinical trials, as we did with chemotherapy. As we said, those have led us to some mistakes or errors. I don't know if you remember the I.M.S.S study with gemcitabine for lung cancer, and the principal author would say the drug doesn't work. We were making the mistake of developing scientific research methodology on clinical trials with concepts that were not truly designed for precision medicine. So this makes us that whenever we progress over time with smaller subgroups, the classical concept of phase 1, phase 2, phase 3 trials, comparing them to prior therapies to hundreds or thousands of patients, that will be very complicated. And in fact, we now have these new concepts. This is why regulatory agencies such as the FDA, I.M.S.S, all of them are telling us that we should conduct these type of studies in order to have agnostic indications or derived from the molecular alterations that we may find. The umbrella trials, the basket trials are clear examples of how within the same histological type we can find several therapeutic alternatives. And in the basket, irrespective of the histology, if we have a specific alteration, we can indeed test it and get an indication, as we will see some examples later, like the TRAC alterations that are developed as basket trials. So this would be the landscape of what we have to break down within my presentation, all the molecular alterations that are potentially treatable. We have robust evidence or approval by the regulatory agencies. So we will focus on the most important part of this Camembert diagram that we know. Blue is something we don't know. We won't be focusing on that, but we will be talking about the rest of them. In order to talk about treatment, as I said earlier, we must have diagnosed patients. This is what the Medical Oncology Spanish Society tells us in the latest review, together with the Society of Pathological Anatomy, on what to do to patients, EGFR, ROS, and BRAF. Basically, these are the therapies that we had approved at that time in Spain and that were paid for. HER2, MEK, RET, NTRK, and TMB at that point in time, because that was a tool that could help us decide the therapy. The American College of Pathologists and ASCO, ESMO, show something similar. Most tests would be the same: EGFR, ALK, ROS, BRAF, and optionals, BRAF. If it is not mandatory, KRAS, that at this time KRAS has become compulsory. RET, that would be compulsory in my mind, and MET, and ERB2, that are also compulsory in this context. We need to be aware, we need to make the analysis of real needs of what you need. And I think that what we need is biomarkers for which we have approved drugs. And the main effort shouldn't be on our patient to run a test with 2,500 genes, but at least for all patients to have the tests that we have drugs for, so that we have unknown patients. This is the worst we can do with such patients. Something that would be desirable if in the neighboring area, in the region, we have studies specific for specific alterations. We need to make sure that these patients get tested for that specific alteration in case there's a patient that could benefit from that. And of certain interest, as I said, for these studies. Just as a summary to what the Spanish Society of Oncology said, we need to change our chip. I'm not a believer of molecular biology techniques for the sake of them, but because of lung cancer, the access to sample, the quality of sample, running monogene tests, eats up all the tissue. So when we make ALK and others, at the end, we don't have much left to work on. We have to evolve towards a histological diagnosis and to carry out NGS based on what we need only. We need to remember that based on it, we need to know the sensitivity and the specificity of the technique that we're using. We need to know the amount of tumor that we will need. We need to know the response time and also some considerations that we can discuss during the round table. This is the capture techniques or the applicants that can give us a different vision. Since liquid biopsy is a hot topic, I am an advocate for liquid biopsy, especially for precision medicine lung cancer. Liquid biopsy gives us an advantage versus tissue biopsies. These are quicker. We no longer have to do paraffination. We will not see different variations per lab. Also the artifacts of the tissue. We can also run several time points of a specific patient to know the diagnosis and the resistance mechanisms, or at least to have an idea about the resistance mechanisms. Therefore, liquid biopsy has changed the landscape. It is not replacing, but rather supplementing the medicine with something more. Then we have another problem, which is the molecular tumor board. I'm sure that there must be institutions that already have it, but in terms of precision medicine, we'll have the need to create molecular committees associated to that. They will start with lung cancer, but they will be working on others. We need to remember this because molecular reports need to have a clinical endorsement. We need for them to be validated based on the evidence they have in order to indicate an off-label therapy to a patient, a compassionate use, or a non-approved treatment. Like in France, for example, we need to have the report of a molecular committee in order to have access to a therapy that will not be reimbursed by the system. If you have the endorsement of the molecular committee, they will reimburse the drug and you can have access to such drug. We will be breaking down the standard of care based on the various alterations and alternatives that we could have. EGFR, this is a little something that was published some months ago. This would be today's landscape. This is patients with EGFR, common EGFR alterations in 21. We can see whether they have cerebral disease. Cernotinib, I think, in my mind, is the standard care in first line on patients with lung cancer. Also, we will need to wait for the approval. If they have not received cernotinib, if they have it or not, because if they develop, they should receive this as a second line, cernotinib as a second line. if they have received sunitinib or if they don't have T0909, then the doublets, chemotherapy doublets would be standard of care of these patients. And after that, we will also see the mutations of exon 20. It is important to see that we have evolved in EGFR versus first generation and second generation regimens of afatinib, DACO, that were gradually increasing all the way to the third generation drugs with PFS close to 19 months, or even the combination regimens. Especially in my mind, it is interesting to see the anti-angiogenics TKIs. They play an important role in EGFR mutations. We will be increasing this construct of lines and overall survival of patients with mutated EGFR lung cancer. These are the data that are standard of care. These are data from the FLORA studies in first line, first generation versus third versus sunitinib, both PFS as well as overall survival for all subgroups that the study was stratified for are beneficial for this experimental therapy. I don't know what your reality is in terms of access, but you know, this would be our reality. It is true that due to Asian studies, now we have the possibility of complementing osimertinib with chemotherapy. This is an Indian study. There was a global survival that was higher as compared to only one TKI. We have FLORA-2 trial. The recruitment is over, and soon we will have information to see whether we should add chemotherapy to a TKI, and if that's better or not. This is counterintuitive in the concept of precision medicine, and perhaps we will need to see the data, how impressive they are. Perhaps those concepts of combining chemotherapy plus one TKA could be okay if we have in a setting with little access and a patient with EGFR mutation can only receive chemotherapy and TKI, because later we will not receive any further therapy. We need to see how the disease progressed and to try to treat this patient specifically. So we need to pay attention to this study, because this study will be very interesting. What happens after using osimertinib? As we said, this is the standard of care. Well, it all depends. All depends whether there's oligoprogressive disease or if the patient has a disease with FETM progression, oligoprogressive disease. In that case, we can extend the benefit of osimertinib and to conduct local therapies. Generally speaking, with radiation therapy, that could give us some benefit over time and to prolong it. But if, on the other hand, we only have a classical progression, we would need to see how has they progressed, and EGFR in all patients, in EGFR specifically, for each progression, we need to run a molecular test. This test needs to take a new biopsy or liquid biopsy, and this is critical. If we don't have an idea of how the progression is, at least we know how the patient is progressing. We will run the test, or perhaps the patient has a transformation to small cell cancer. Maybe in that case, the patient needs to receive chemotherapy plus new anti-angiogenic or chemo and radiotherapy in small cell carcinoma, but we need to have some progression mechanisms that are parallel and that are taking place, such as acquired fusions or mutations or MET amplifications that at the beginning in lung cancer were important. We didn't know how to study them well. Now perhaps they will play a role. In fact, savolitinib plus osimertinib in this trial, this is in early phase patients that could have received or not osimertinib as treatment for their disease, and those that hadn't got it, those that didn't have 09 and those that had, or the overall population, we see that if they have overexpression of MET, in fact, it is interesting to see the definition they make about MET. We have had trouble doing many studies on how to define MET. Is it through FISH, histochemistry, and with copy number over 5, with a ratio over 2, with simple immunohistochemistry with C with 3 crosses, or the number of copies of 5. So here we can see that the combination of anti-MET and bosutinib in this case in naive patients increases the response rate all the way to 60% as a mean. The PFS in patients after several lines is in around 9 and 11 months. Therefore, we see that MET plus 1 TKI of EGFR may make sense in patient molecular alteration. So this paves a way for this important study. I think this is a Rosales study that is mainly focused on patients that have received, that have progressed to a certain. This is a combination of one third-generation drug, which is acertinib. In this particular case, it is a drug similar to osimertinib plus amivantamab. This is the anti-EGFR, anti-MET antibody. It has an immunomodulator effect, and it can target EGFR mutations, MET overexpression, as well as MET mutations. And in fact, the combination of these was presented this year. We see a response rate in polytreated patients of 36% with a mean
de casi 10 meses y en torno a 5 meses con un perfil de toxicidad realmente bueno. Si nos fijamos, son pequeños números, pero si nos fijamos cuál es el mecanismo de sobreexpresión de MET o cuánta sobreexpresión de MET tienen estos pacientes, si realmente, y nos fijamos, yo creo que esto aquí, esto es para atrás, no tiene láser, si nos fijamos en la parte de abajo, en los que tienen inmunohistoquímica positiva para MET, vemos que la tasa de respuesta se eleva hasta el 90% en estos pacientes, lo cual, si el mecanismo de progresión verdaderamente
is overexpression of MET, then it makes sense to use such strategy with a very high response rate. If the analysis is through LGS and the resistance mechanism is a 5-copy number of MET, we see that the response will be a deep response. However, we have other type of alterations such as C7, I.M.S.S or amplifications or P3K, P10. Perhaps that could be very different from the others. In that case, we need to be a bit more careful with the drug. Another mechanism to revert conversion to osimertinib, the appearance of MET, not the appearance of MET, but also therapeutic target on E3. E3 is present in many of the progression mechanisms of the driver techniques, or what we draw that you know well. This is close to trastuzumab, and this is close to trastuzumab, and this as an antibody that has CPT11 metabolite attached to it. So patients that have used osimertinib with response rates in around 40%, and even with effectiveness in the CNS with response rates also 40%. So this has hopefully the EMA will soon give the approval. So what happens if this mechanism is in EGFR? Because when we were talking about osimertinib, we were talking about the same mutation, E79. No longer we speak about that mutation, but we speak about E3, MET, and other things, because it seems that the therapeutic alternative that we would get to target EGFR plus minus T709 plus minus C797S would be to use citinib. Perhaps some patients would become sensitive again, but we need to pay attention to the EGFR 4th generation drugs. In this particular case, Blue 945, that is in a recruitment stage, in an early stage, but at least we have data, lovely data, with the cell lines, with PAD3 models that have mutations in FIS with or without the mutation of EGFR. That blue monotherapy is efficacious, and in mice models derived from humans, in the other graph, we see that if, in addition, we combine with a 3-generation inhibitor or with ensitimib, as we said at the beginning, the control of the disease will be the lower curve. It is almost total control versus non-giving treatment to these patients. Exon 20. We said before that historically, exon 20 chemotherapy. This is not a driver disease, and that's it. I think that at this point in time, this regimen of chemo and docetaxel has changed with 2 drugs. Mobocertinib, which is a TKI inhibitor, and what it does is that targets exon 20. This is a phase 1, phase 2 trial with several cohorts, and we mainly focus on those patients that have received this drug, having exon mutation in exon 20, and we see that the response rate, in fact, is very good, and the duration of the response is good, and the median, PFS median, is 8 months. These patients would never respond to immunotherapy. In fact, we were wondering to prescribe, but in advanced lines, yes. So these data really show us to treat these patients. And an old friend of us, which is amivantamab, that has been approved by the FDA. In Europe, it is in process for exon 20. These patients with this drug that we said, anti-GFR, anti-MET, that target at least the EGFR mutation, and it gets a very good response rate. It varies depending on where the mutation is, and this is prognosis information for patients. If it is closer or farther away from kinase, this is the loop, the kinase loop, and we will have some response rates which will be smaller or larger depending on that. ALK. I think that there are many things on ALK that are changing our mind, and quicker than EGFR. We had historic data of certinib that the failure in CNS, and now we have ways to revert it, such as with alectinib, with a PFS that you all know very well. We have also data from CROWN, lorlatinib versus crizotinib. If I'm not wrong, at the end of the year, we will have the Brown study results, and it seems that that will be good. We will need to see whether that's enough for the toxicity of all of this, and whether this will be the new standard of care. But we need to look at the ratio as well as the medians. But I have my questions in terms of toxicity of this drug. We need to pay attention, especially to new valent and TBX. Here I can show you some examples. These are 4th-generation drugs that revert resistances to lorlatinib, because this is the best inhibitor. Here we see once again that these are PAD3 cell line studies, and if we have the Kuiper G1202I mutation, TPS 031 gets control of the cell volume that we have. And so those would be the violet or the purple lines, and individuals with double mutations, G12-0R, and other mutations such as PL1198 or 96. In fact, we see that TPS at different concentrations can achieve good disease control. This is what we will see with ALK patients after they have been on lorlatinib, or Norvali also has data better than TPX, but we need to pay attention to these drugs for the future. We have crizotinib with response rates that are spectacular, with better PFS for ALK. Once again, on the table we have retrontinib and entrectinib with very, very good high responses. These are new generation inhibitors that do not work if crizotinib has been given to patients before. These are for first line. The therapeutic advantage, if they have received crizotinib, is to between 35–30%. Therefore, we need new drugs under this scenario. BRAF, this is a biomarker that I don't like personally. I don't know why, but I don't like it because of this data, because it seems that it doesn't matter if you give it in first, second line. This is a dirtier driver. This driver responds better to immunotherapy. Driver is more associated to tobacco. And I think it has its relevance. It has its own relevance. Also, as a resistance mechanism to other driver or cleaner driver mechanisms like EGFR that may appear, where these alterations may appear, and trametinib, dabrafenib is the standard care for these MET patients. MET, this last year we saw in New England with tepotinib, and the problem of these inhibitors, as all MET inhibitors, are the secondary effects, but the response rate and the survivals that we get with these drugs on tepotinib and capmatinib are worth, with response rates of almost 70%. If you have had the opportunity to treat one of those patients with these drugs, the side effects are not easy to manage, but the control of the disease is a good one. RET, this is a complex gene. In lung cancer, we speak about targeted therapies for RET, for fusions, not for mutations. There are thousands of PET mutations that we know what they mean, and perhaps many of them may be mediating disease progression mechanisms towards other target therapies. Here we have the selpercatinib, 60% response rate, the duration median almost 18 months, and also we have pralsetinib with response rates that are really spectacular. Also, potentially with a relevant role in the progression mechanism with some fusions, especially in patients with EGFR mutations.
Very quickly, HER2, the other friend is trastuzumab for HER2 mutations in lung cancer. We know that the overexpression of HER2 does make sense. We treated patients with overexpression and mutations with trastuzumab, Taxol, plus trastuzumab with TDM1, with all the copies of the breast with these patients, you know, or in these patients with not much success. We see response rates of about 50% that we got with a TDM1, did not reach 20%. And I think with a PFS median in 8 months, the drug is here to stay for mutations of HER2 in this arena. The PFS median is 8 months. And to end, this is the precision medicine of basket trials. I don't know if you have treated patients in TRAC or have found a patient with TRAC. They're impossible, really. In Madrid, on October 12, in a program, we did 1,600 screenings, and we found 6 patients. We found a lot for what there is, but it really is a tough job. It's true that when you find a patient like this, the response rate is very good, and we have first, second, and third generation inhibitors with response rates of about 70%. With larotrectinib or entrectinib, it's not a Q, it's an A. In lung cancer specifically, with these responses, we are planning to do screening. And I want to end with the jewel of the crown, which is the untreated disorder that's always there. You might recall when we started doing EGFR mutations. So we do KRAS because it's easy, it's implemented, and if it's KRAS negative, we'll do the rest, right? Well, KRAS now, thanks to especially 12J's GC, it's not the only therapeutic target, KRAS in lung cancer. This is the information from ASCO of last year that is very prevalent. G12C in lung cancer, it's the most frequent one. It isn't frequent as a mechanism of progression to other targets, but G12C and G12B, for which we have drugs, we will have to find how come G12C doesn't appear as a progression mechanism. However, it is the most frequent de novo in these patients. And basically, we have sotorasib. This is data. We're not talking about just the phase 1 and phase 2. We have response rates, not the ones we expected with red and track. They're lower. It's not such a clean driver. It's what happened to BRAF, for example. But it's interesting. I think the survival means progression with the progression-free and the progression-free survival. Some of these patients, died faster, but they're living more than 1 year. I think it's the standard of care. I don't know if you have access here in Mexico to sotorasib. There are others in the competition, such as adagrasib. In the lab, it behaves very well. Apparently, clinically, it does as well, with response rates a bit superior compared to the ones of sotorasib. And now it's an absolute war, not just between these two drugs, but also KRAS, G12C from Roche, Novartis, Janssen, and all the trials that are taking place to see who is going to get it. I think it's going to be a combination, not just with immunotherapy, which is the obvious combination that we think about, but also with other therapeutic targets in the scenario of patients with a KRAS, mutation of KRAS. And I end with this slide. I think it's important to state, to create the precision medicine programs and resistance studies. Basically, this is what I do. Right now, aside from developing new drugs, this is the MATCH, R, and STING protocol. It's the precision medicine program, both liquid and tissue and rat models of cell lines to help see the progression mechanisms of a patient, doing the analysis also, and a whole range, to help a patient and to help the drugs for the escape mechanism and provide targeted treatment. And the final message is, I think that precision medicine is the way to have access to the increased survival of our patients with lung cancer, that the new drugs and the new diagnoses for patients and the discovery of drugs will be important for molecular disorders that represent 1%. Otherwise, it's going to be impossible. And academic studies, as I said, will be essential to understand the resistance mechanisms in these patients. We have to open our minds to the combination. I think this question of whether I have two disorders at the same time, what do I give them first, A or B? And this is a paper showing in the MATCH-HER trial sequencing. What we see is different alterations in the FR and BRAF, EGFR, EFR. They're not different cell populations. It's the same cell with two disorders. Maybe the cell doesn't use one, but in biology, but if we block one of the drivers, it will surely use the one next to it. So,
combinación para mejorar estos pacientes. Muchas gracias.
Muchas gracias al doctor Ponce por la excelente charla. Seguramente surgirán muchas preguntas que esperamos recibirlas al término del módulo. Ahora me permito presentarles al doctor Rafael Rosell. Él es director médico y presidente del Instituto Oncológico doctor Rosell, también director del programa de Biología del Cáncer y la Medicina Personalizada en el Instituto Catalán de Oncología. Y pues sin más preámbulo, vamos a darle la bienvenida. El doctor nos va a platicar sobre la otra forma de tratar a estos pacientes con cáncer de pulmón, que es a través de inmunoterapia. Veremos algunos avances y perspectivas. Muchas gracias, doctor Rosel.
Hola, buenos días. Soy el doctor Rafael Rosel. Para mí es un honor estar presente hoy en este congreso en Monterrey de la Sociedad de Oncología Mexicana, la SMO, y también dar mi aprecio a los coordinadores, los doctores Rogelio, Trejo y el doctor José Francisco Corona, distinguidos colegas, miembros de la Sociedad Mexicana de Oncología y invitados. El tema de hoy es hablar de inmunoterapia.
Buenos días. Tengo algún problema. Pensaba que se había grabado y se había enviado previamente la presentación.
Pues, en principio,
no sé si la organización puede pasar la grabación o puedo
del tratamiento de cáncer de pulmón con inmunoterapia.
Y gracias. Si se pasa la grabación, luego me uno
pero
al
ya en
término de
el
las
año
preguntas.
2005 se apreciaban ya publicaciones en ratones donde el bloqueo, la inhibición de la expresión del PDL1 en la superficie de las células tumorales era muy importante y desde entonces se ha considerado un escudo protector del cáncer, de la progresión del cáncer, y realmente el desarrollo de inhibidores de PD1 y PDL1 ha sido muy importante. Y también hoy también indicar que independiente del PDL1 en la superficie de la expresión del tumor, el reconocimiento de los neoantígenos, de los complejos de histocompatibilidad mayor, principalmente clase 1, son de gran interés. Todos tenemos casos positivos. Tenemos el Keynote 0189 de combinaciones de pembrolizumab con carboplatino, cisplatino y pemetrexed, luego el mantenimiento, y que ahora en julio se ha publicado en Annals of Oncology un update, un seguimiento del estudio original publicado en el 2018 por el doctor Delvis Rodríguez como primer autor, y realmente los resultados siguen manteniéndose en el tiempo. Y aquí me permito pues un caso nuestro, de nuestro centro, donde un paciente, en principio mal pronóstico, es fumador con adenocarcinoma pulmón, metástasis cerebrales, óseas y pulmonares, pues tuvo una remisión completa de la enfermedad.
Complete remission of the disease
Todavía está en tratamiento de mantenimiento.
in the treatment. So this was reviewed in our center, and they determined a KRAS mutation, and others were polymorphisms and other disorders with unknown significance. And this is what gives us some hope when we treat patients with lung cancer. However, as you know, there's an immunotherapy response. We see a malfunctioning of T cells because there's overexpression of negative receptors of immunity, starting with the expression of PD-1. In T cells, there's loss of effector cells, loss of function of factors that destroy the tumor. And there are other negative receptors like LKB1, and there are other new markers with multicolor immunohistochemistry techniques. We can have a more certain examination of the tumor histology, including there's a prognostic factor. Perhaps what is interesting here is to know that the frequency of EGFR mutations is high in certain regions, mainly in Mexico. We know that immunotherapy as we know it, different trials, the activity has not been demonstrated. So with TMB or the tumor mutational burden, we have lung cancer, in spite of having the burden and loss of LTB1, these do not respond. And also the KIAP mutations that are coexisting. As I said before, there are many co-receptors that are upregulated in and the results similar to other inhibitors. So do we need so many monoclonals or PD-1 or PD-L1 inhibitors? What is the difference? But these are studies that are appearing. These are the guidelines, the recommendation guidelines from the ASCO that are simple. These are those of the Society of Cancer Immunotherapy that are similar, and we all follow. Perhaps one of the things we have is that when there are target mutations or driver alterations, if the TMB is low, there is no PD-1 expression. There are markers that indicate that there won't be an immunotherapy response. And this is frequent in, let's say, the classical mutations. Many times, TMB decreases. So I recommend, this is from John Heyman's group from the MD Anderson, with over 4,000 cases of lung cancer with genetic alterations. And I wanted you to pay attention to the mutations of EGFR, and on the other hand, the KRAS mutations, in spite of having higher values of PD-L1 and of having mutational burden, the progression-free survival is relatively low. In the European Congress of the ESMO, when comparing atezolizumab with chemotherapy, we see that in spite of high TMB thresholds, there were no differences. So here's the discussion. We have to look for antigens, and in lung cancer, there are two large groups, the EGFR and in KRAS, and there are subfamilies. I'm so sorry, but the sound is awful. we have to take into account PD-L1 in the cytoplasmatic position if it's internalized and there's negative expression of the cell surface. And in the ESMO, patients who progress to first and second line immunotherapy inhibitors. This is a study plus sitratinib. It's an oral drug, a tyrosine kinase inhibitor. That it's from the tyrodermal TK. In this trial, in patients previously treated after the first or second line with immunotherapy inhibitors, nivolumab has a survival mean of 15 months. Because of time constraints, these are the multiple causes why the EGFR mutations don't respond to immunotherapy inhibitors, such as the excess production of adenosine, like CD39, CD73, and therefore it is a field of great interest. We know that in the MD Anderson, they saw that the adenosine receptor, especially the A1 receptor, is more elevated in patients with lung cancer. We had EGFR mutations. And to block adenosine, it seems that it is a pretty, it's a main line that we have to consider in lung cancer with EGFR mutations when we see these Kaplan-Meier's of these patients in red. So there are many papers. This is a recent one in hepatocellular cancer. The hypoxia favors the expression of CD39, and this is adenosine, the inhibition of PD-L1, the resistance of immunotherapy, and chemotherapy can play like the same function. And this is a process of hypoxia on the different forms of hypoxia. In a more recent study of the keynote for second line, the survival is maintained. The survival is significant regardless of the PD-L1 status. This is a great paradigm because it's not reflected in the progression means. So there's a great difference between progression-free survival and overall survival in all the studies. So to me, it is an honor to go over Dr. Oscar Arrieta's program. So we have pembrolizumab plus docetaxel, and which is superior to docetaxel. We know that docetaxel is for clinical trials, and the patients who had EGFR mutations, there was a significant improvement, not as marked as those patients without mutations, but it also indicates that there can be, some place for immunotherapy. So it's important to know the function of immunotherapy with EGFR mutations, especially in Latin America, especially in Mexico. In purple, we have the deletions of the exon 21. They're much more frequent than KRAS mutations. And we have more predominance of KRAS mutations, and they're accompanied by mutations and loss of p53 function, and the loss of p53 is universal in over 60% of these tumors. What is the function of immunotherapy? Other alterations are the loss of LT1 or K1. There are other alterations such as, I'm saying all of this because we know how to use the NGS to treat tumors with liquid biopsy, and it's normal to find mutations and alterations in KRAS. In lung cancer, there's loss of mutations in chromatin gene that repairs DNA. Loss would indicate more sensitivity to certain agents like carboplatin. And there are others that are important like KIAP. This diagram is very important because it indicates the division between KRAS mutations with a KIAP mutation on REA1A, or these mutations are less frequent, but they coexist sometimes with EGFR mutations. And this is a work from July of Cancer Discovery. We see that patients with the EGFR mutation, the coexistence of mutations in KIAP influenced the response to osimertinib, as we see here. So because of time, it's important when we go over OAK, atezolizumab versus docetaxel in OAK. This is the example. When you go through NGS, the mutations indicate poor prognosis. And if we add mutations, it means a worse prognosis. So we have to, I think it's important that KRAS mutations are important. And we have to look at the solutions of this. This is a very recent study from the Netherlands. In second and third line, patients receive pembrolizumab and nivolumab. And in the trial, the coexistence of mutations or of STIC11 and KIAP dramatically influence
progresión en rojo y en la
time to progression
supervivencia.
in red and survival.
Todos recordamos el estudio
We
original
all
de la
remember the
M.S.S.
original trial from the MD
que
Anderson
las diferencias en presencia o ausencia
or about the
de
differences in
pérdida
the
de
presence
función
or
de este gen
absence of the
supresor
loss
STIC11.
function
La
of
razón no
this
se sabe.
suppressor gene
Curiosamente, estos
STIC11,
pacientes tienen más
STK11.
TMB. ¿Cómo
but
puede
patients
ser
have
todo
more
esto cuando se
TMB,
comparan tumores que
and
tienen solamente en
when we
azul
compare
la
tumors
mutación de P53 con
when
los
they
que
have
tienen
the
del QB1 en
p53
rojo?
mutation
Vemos que
with the
los
ones
antígenos de presentación, los
we see
receptores
the
HLA,
presenting
HLB,
antigens
HLC, las subunidades de inmunoproteasoma, otros
and the
transportadores, todos están disminuidos y por lo
transporters, they're
tanto
all
no hay
decreased, and
presentación
therefore there
de
is no
HLA para el
presentation of
reconocimiento de los
HLA
linfocitos y
to
por lo tanto para la
recognize
elección de la
lymphocytes.
inmunoterapia. ¿Qué hacer cuando no hay presentación de los complejos de histocompatibilidad mayor? Este es un trabajo bastante singular que solamente dos citostáticos, oxaliplatino y mitosantrona a dosis bajas, son capaces de estimular estas subunidades de inmunoproteasoma, los transportadores o los complejos de histocompatibilidad mayor para reconocimiento de la generación de interferón y la activación de los pathways. Como decíamos, pues es bastante fascinante. Son aquí 3 líneas de carreras de cáncer de pulmón. Lo que se llama PIB-B es el control y vemos que sin reintroducción del QB1 no tienen reparación del DNA cuando se causa daño celular con un citostático neocarcinostatin. Las líneas de Carras con P53 tienen buena reparación del daño celular, como se demuestra en el Wedge 51, pero no en las líneas que tienen el QB1. Por lo tanto, podríamos ya decir que no hay reparación del DNA. ¿Qué soluciones tenemos? Pues solución, pues fármacos tipo cisplatina o carboplatino. También en estos trabajos se apunta que hay un aumento de autofagia, que inhibidores de autofagia específicos, concretamente inhibidores de ULK1, como algunos que están ya en experimentación clínica, pues pueden ser de utilidad. Hay muchos otros aspectos que olvidamos en la presentación de los complejos de compatibilidad mayor. Un 20% de cánceres de pulmón no pueden tener, aunque tengan la interferón bien activado, bien expuesto a través de las células T. No se reconoce por el complejo de histocompatibilidad mayor porque se degrada cuando hay un defecto en optineurina. Por lo tanto, hay muchas oportunidades de crecimiento. Y en P53 es promiscuo, está mutado en más del 60% de casos y el P53 inhibe subcarril 17A11, que es un transportador, un inhibidor de ferroptosis y por lo tanto ya tratando con inhibidores de ferroptosis pues tendríamos un gran avance y por lo tanto aquí por ejemplo la radioterapia, como ya han hablado antes el doctor Adolfo Fernández Díaz, pues la radioterapia per se estimula interferón, pero la radioterapia si no hay P53 puede ser también negativa en el sentido de estimular la vía del subcarril y el GPX4 que inhibe ferroptosis. También las mutaciones de P53 por otros mecanismos en cáncer de pulmón pues bloquean la activación de interferón y por lo tanto niegan el efecto que necesitan las células natural killer y las distintas subpoblaciones de células linfotóxicas. Voy por tiempo, en aras a estar dentro del tiempo. El durvalumab ya se ha comentado, hay otros estudios que dan fe de la potencia. Simplemente decir, si no se ha comentado previamente, pues que las mutaciones de P53 importan por el efecto de la radioterapia, como vemos en este Kaplan-Meier, y esto es por el hecho que la radioterapia en ausencia de P53 pues induce una activación de subcarril 17A11, que es lo que inhibe, crea radioresistencia. Por lo tanto, cosas tan fáciles como tener en cuenta la estratificación de los pacientes que vayan a recibir tratamientos tipo Pacífico, muchos ensayos que hay en curso, pues tener en cuenta el efecto que pueda tener potencialmente negativo la presencia de mutaciones de P53. Simplemente este es otro caso también muy reciente de este año, pues que a pesar de ser un paciente fumador, adenocarcinoma, hizo también una respuesta completa al tratamiento, a pesar de una complejidad de conmutaciones. O sea, para terminar, podemos decir algo que es digamos, un poco redundante la respuesta de Immune Checkpoint Inhibitor Therapy, lo que entendemos por llanamente por quimioterapia o inmunoterapia con anticuerpos PD1 o PTL1 es compleja. Desde aquí invoco pues la facilidad que tenemos, ya que tenemos disponible de forma diaria el NGS, pues que las mutaciones de Carrasco en el KIP1 o KIAP merecen pues tenerlas en cuenta, en primer lugar porque tienen importancia predictiva, en segundo lugar porque se presume que pueden tener tratamientos de repurposing fármacos, tratamientos sencillos, las mutaciones de P53 hay que saber que están allí y que no son precisamente inocuas y que, bueno, que hay muchos ensayos clínicos en marcha y que la quimioterapia quizá en el futuro tendría que ser más excelsa y no dar la quimioterapia tal como la entendemos, enjuiciamos y prescribimos hoy día, y que el tema de mutaciones de EGFR es un problema en cuanto a cómo poder incidir con la inmunoterapia y se necesitan algunos estudios translacionales para aclararlo. Muchas gracias por su atención y por esta oportunidad y encantado de participar en la discusión. Gracias, compañeros, amigos, gracias.
Agradecemos mucho al doctor Rosel por su
presentation. We are in the last minutes of this agenda. I would like to know if someone has a question for the experts panel. Any questions? Yes, I have a question here for Dr. Ponce.
Esta molécula tan interesante como amivantamab y lazertinib en pacientes que no tuvieran alteraciones en MET, es decir, tendría
alterations. Perhaps it would be worth using this drug in absence of a molecular alteration. The data that we have, patients with other alterations that were not related to response rate, is not really helpful. I don't think this would be the way in which I would do it myself.
De acuerdo.
Okay.
Muy bien.
Good.
En pacientes que tienen
Patients having complex mutations,
sobre la posibilidad de tener de forma concomitante, por ejemplo, mutaciones en EGFR y en alguna otra
other pathways.
La posibilidad de que la enfermedad escapara si únicamente se bloquea una vía. Al día de hoy tendría alguna sugerencia en particular, es decir, posiblemente los pacientes empezar con tratamiento con quimioterapia. En un contexto quizá como el nuestro, donde posiblemente tener acceso a algún
Perhaps they will have access to the research protocol where we can combine therapies.
¿Dices un paciente que haya hecho osimertinib o que haya hecho
Patient with osimertinib or a patient with a complex mutation in EGFR, like EGFR and KRAS in the first line of treatment? All depends on the mutations profile that they may have, how the disease starts, and perhaps the option you're telling me about would be the most practical. Is it to start with chemotherapy in patients? I think it is different. If this is a progression, if this is a baseline, for the KRAS value, if this is present, if you have mass sequencing, or if it appears at the beginning of the disease, as a progression mechanism. I think that yes, with KRAS, this is particular. Something more to talk, but we have alterations. The driver, we can treat. This is red, and we have data that makes sense.
No solo los datos de
They published not only certainty data, but also retrospective data, even with low allele frequencies in liquid biopsy. That was published in ASCO this year. It makes sense to treat these patients, although intuitively these were not very high. So we have benefits with the allele frequencies, patients with partial responses.
Bueno, es una vía de combinación a la que no estamos acostumbrados. Obviamente la toxicidad en los pacientes va a ser algo en lo que tengamos que luchar, ¿no? Las dosis.
We need to see the doses as well and the combinations. But I think that.
De acuerdo. Muy bien.
Okay.
Doctor Alatorre, por favor, encantado de escuchar.
Please, your question. Thank you, Santiago and Rafael. It's nice to hear you with all of what you're doing. Both in the research area, this is really outstanding. And thank you for joining us. But something that is really interesting in TKIs plus immunotherapy is what you were saying, Santiago, about the combinations that in KRAS and BRAF, because these patients are mainly smokers, but in the subgroup of patients of KRAS, are there some that have mutations in CDK11, less inflammatory tumors, and others P53, more inflammatory? So with all of these, in single cell analysis, this in the future allow us to select these combinations.
Digo, obviamente faltan resultados, pero que suenan muy interesantes.
No sé si el profesor.
I don't know if the professor wants to take that question or no.
Simplemente un muy breve comentario. En principio, ya como dije.
Rafa, estás en mute.
Estoy.
You hear me? Yes.
Disculpa, no quiero ingerir porque está aquí presente mi compañero doctor Santiago Ponce. En principio lo ha matizado muy bien el doctor Ponce.
Ponce said it right. Yes. In the case of immune therapy, practically 60% of patients with KRAS mutations have TP53 mutations. It affects little in terms of the response time, etc., to immune therapy.
El doctor Adolfo Fernandez.
Dr. Adolfo Fernandez said it right. The effect of radiation, TP53 mutations. These are EGFR mutations in most cases, and also B53 mutations, KRAS. And there's a doublet of KRAS B53 mutations. Till now, as we know, the effect of immunotherapy is greater as compared to KEA111 mutation that is in 20%. This is how we have reviewed. They have a high TMB. This is a paradox, because it has no recognition of histocompatibility antigens. Therefore,
líquida, pues importa pues en un futuro
próximo, casi diría de inmediato, el saber que KRAS,
It is important to know that KRAS,
de los fármacos orales inhibitorios y que se necesitan combinaciones para KRAS G12C,
KRAS,
en principio cuando tenemos el tema de la inmunoterapia,
immunotherapy,
a nivel preclínico nuestra experiencia
in a preclinical level and experience,
no
it's not
influye en los
much,
resultados
but it doesn't have an impact on the results.
resistentes a la M510 que se llamaba antes, etcétera, no influye demasiado.
Doesn't really have an effect on the molecular characteristics of KRAS, P53,
El triple mutación, por supuesto,
or triple mutation.
pero en la inmunoterapia parece que implica,
For immunotherapy,
el TMB, o al menos es
there's,
algunos estudios recientes como el BIFAS, que todavía
there's some studies like BRAS.
porque con alto TMB, pues los pacientes no responden como se estaba
Patients do not respond as expected to the immunotherapy with those mutations. They're relatively sensitive studies in order to know where they have TK11 that coexist in 20% of KRAS.
Y con esto me disculpo de haber intervenido en una sesión que ya es más larga de la cuenta.
I apologize for having intervened in this session that is really taking long. Thank you.
Un placer siempre escucharte, Rafa. Además, hacía mucho tiempo que no nos veíamos, así que... ¿Y cuál sería, Rafael, tu
Rafael, what is your recommendation for
desde el punto de vista práctico,
a patient? Practically speaking, a patient that has EGFR mutation and at the same time P53 in the baseline. So what would be your best therapy for this patient?
Al igual que has explicado ahora, ¿no? P53 puede estar modulando, ¿no?
P53 may be modulating the response.
Bueno, aquí tenemos todos compañeros, tenemos muchos.
Here we have several colleagues. Dr. Alatorre that is asking us, and the moderator, Dr. Oscar Arrieta, and many other colleagues about EGFR mutations, the European, the Spanish. I don't dare to give an opinion or to give you some recommendations. But yes, the P53 mutation coexists and it shortens the duration of the response or the PFS. This is what we know of the studies that have been carried out. But in the clinical practice, it is true that even in GS or not, EGFR mutations, we treat them as with monotherapy. As it has been said, to see what type of treatment combinations we have to avoid such resistance mechanisms, irrespective of MET amplification. Dr. Pasillanes' group, as you know, published on September the 1st that MET amplification in human lines of patients derived from pleural fluids. They have seen that MET amplification, when it exists, oftentimes affects the EGFR mutation. You don't need to inhibit the EGFR in the MET mutation. You need a MET inhibitor.
De la atracción que tiene todo este campo y en principio, básicamente retornando al punto inicial, Santiago, yo creo que mejor que yo mismo o los que están presentes aquí en la sala, el propio moderador, todos ustedes pues pueden testificar y aportar comentarios interesantes que lamento no estar físicamente con ustedes.
Muy bien, muchísimas gracias, doctor Rosell. Excelente charla por sus respuestas. Muchas gracias.
Thank you, Dr. Santiago Ponce. Dr. Adolfo Fernandez. And we will conclude the agenda on chest tumors, and later we will have new talks. Thank you all for your attendance.
Tenemos 4 ponentes extraordinarios. Vamos a hablar de los avances en terapia sistémica para
Systemic
enfermedades.
therapy for resectable disease. Next. I want all 4 pictures there. We have 4 speakers. Dr. Patrick Forte, that just to give you an idea, he was the leader of the paper published as an exploratory study on the use of pre-op immunotherapy for patients with resectable lung cancer. Dr. Vanessa Garcia, that will speak about adjuvant therapies, and 2 extraordinary surgeons, Dr. Mara Antonov. She is a surgeon from ND Anderson Cancer Center, and she will tell us about lung metastasectomy, but we thought that metastasis surgery was going to come to the end, and with the advent of systemic therapies, we will have fewer patients with resection of metastasis. And finally, Dr. Brandon Stiles, also extraordinary surgeon, that will talk about recent progress in lung cancer. This is a more conservative surgery, pulmonary segmentomy, similar to lobectomy, and that I'm sure that this will be the new gold standard. So without further ado, we will begin with the 4 lectures, and at the end, we hope we will have a very productive discussion.
Okay. I think I'm first up. Sorry, I'm just going to minimize my screen. So my name is Patrick Ford. I'm a thoracic medical oncologist at Johns Hopkins Hospital in Baltimore, USA.
Estoy en Baltimore, en Estados Unidos, en Johns Hopkins.
And I'm delighted to be with you today. Today I'm going to talk about novel neoadjuvant. Apologies. Sorry, I'm getting feedback on my. I better turn off the translation. My apologies. Somehow. Okay, hopefully this works. So I'm a medical oncologist. I'm going to talk about some developments in neoadjuvant immunotherapy, predominantly for resectable non-small cell lung cancer. These are my disclosures. So the current role, and what has been the role really for the last 15 or 16 years for perioperative chemotherapy, is for stage 2 and 3A disease in the 8th edition. And this is essentially either larger primary tumors or those tumors which are involving the lymph nodes, be they the N1 nodes involving the hilum or the N2 nodes involving the mediastinum. And that hasn't changed up until very recently, the last couple of years essentially. We choose this therapy based on the LACE meta-analysis, which was published by Dr. Pinion and colleagues now 13 years ago. And this looked at 5 large phase 3 trials of adjuvant cisplatin-based chemotherapy conducted from 1995 to 2007, almost 5,000 patients in total. And this meta-analysis showed a benefit of approximately 5% in overall survival at 5 years from the addition of 4 cycles of cisplatin-based chemotherapy to surgery. Interestingly enough, this was made up of a 6.9% reduction in lung cancer specific mortality. However, a 1.4% increase in non-lung cancer death, I think highlighting the patient population that we see with lung cancer, where comorbidities such as heart disease and COPD are common. Similar benefits have been seen with neoadjuvant therapy, and many of the neoadjuvant trials were ongoing at the time of reporting of the phase 3 adjuvant trials, so stopped early. However, meta-analysis have shown a similar benefit of about 5 to 10% in 5-year survival from neoadjuvant chemotherapy. So how do we choose between the 2 options? One of the benefits of neoadjuvant therapy is that it potentially provides the earliest opportunity possible to eradicate metastatic disease. And we know that about 2/3 to 80% of patients who have recurrence after lung cancer have distant recurrence. More patients will commence neoadjuvant systemic therapy and more patients will complete it. Anything from 97% of patients commence neoadjuvant versus about 66% of adjuvant therapy. And more patients, 90% will complete the planned course versus about 61% completing adjuvant courses. There's a potential benefit. We've seen a lot of rapid advances in metastatic lung cancer with drugs almost being approved every month over the last few years. However, these drugs have been slow to be translated into early stage response, which can be assessed after neoadjuvant therapy, is a potential surrogate marker of benefit, particularly in the field of immunotherapy. There's also a theoretical benefit from neoadjuvant immunotherapy in that the main bulk of the tumor is still in situ at the time of the administration of the immune drug. And this could act as an in situ vaccine, stimulating the immune system to continue to surveil in the future for tumor neoantigens. In terms of adjuvant therapy, there are also potential benefits. It allows the fastest time to get to curative surgery, which may be curative for some patients. There's no risk of pre-surgical complications from systemic therapy. However, recent studies, including one I'm going to discuss, have not shown a dramatic increase in toxicity from neoadjuvant immunotherapy. And it does allow for a longer treatment duration. And we're seeing this difference really between the neoadjuvant trials, which are ongoing, and some of the adjuvant trials, between 2 to 3 months of therapy for neoadjuvant chemoimmunotherapy versus 1 year of therapy when adjuvant immunotherapy is used. There's also more flexible timing. The patient has time to recover after surgery, allowing follow-up and allow commencement anything from 1 to 3 months post-surgery.
Pacientes con resección, y esto muestra que 45% de los pacientes tuvieron una respuesta patológica mayor, que se definió como 10% de menor tumor viable residual. Esto se sostuvo en diferentes etapas. Del lado derecho de la pantalla ven que esos pacientes que tuvieron una respuesta patológica mayor, ninguno de ellos tuvieron enfermedad activa. Se les dio un seguimiento a 5 años y uno tuvo una recidiva, pero se le trató con quimiorradiación y no tuvo recurrencias más. Los pacientes que no tuvieron respuestas patológicas mayores, desgraciadamente tuvieron recidivas de cáncer. Y esto muestra la era de la quimioterapia, cuando la quimioterapia neoadyuvante llevaba nuevas respuestas patológicas o completas. Y la terapia neoadyuvante permite un análisis también, como ven del lado izquierdo de la pantalla. Aquí tomamos las biopsias que se toman en esa terapia y vemos el área tumoral. Y luego en inmunofluorescencia naranja vemos que hay pocas células infiltrantes positivas que están presentes y que expresan PD1. Y después en nivolumab, abajo, ven ustedes el área del tumor que está infiltrado con células positivas CD8 y que están expresando PD1, pero está bloqueado por los anticuerpos anti-PD1, lo que permite el reconocimiento inmune.
You'll see that though this was a small study, we were able to demonstrate an apparent correlation between the number of mutations in the patient's tumor and benefit in terms of pathological response to treatment. And this has been shown in some other studies subsequently as well. Looking in the periphery at circulating tumor DNA, and this is a keen area investigation both in metastatic lung cancer and also in early stage disease. You'll see in panel A here, a patient who had on panel A on the left, sorry, I'm getting feedback again.
Teniendo otra vez retroalimentación. El panel A de la izquierda ven ustedes que tienen una respuesta mínima radiográfica en verde. Estas son las mediciones del RECIST, pero una mayor respuesta en cuanto a cómo se resuelve. Y en el momento de la cirugía, esos pacientes no tenían ya tumor viable residual. En ese caso, por lo menos, esta resolución fue un mejor marcador de lo que sería una respuesta patológica, y lo opuesto aplica del lado derecho. En el paciente que no tuvo una respuesta molecular, en el DNA circulante ni tampoco tuvieron respuesta patológica. La capacidad de poder obtener grandes volúmenes de tumor fresco después de una terapia también permite un análisis funcional a profundidad. En este análisis del Dr. Smith y Cassie pudimos hacer un perfil de células T de adyuvantes aisladas del tumor que se perfilaron y veamos cómo se manejaba con el antígeno. Esto antes de una secuenciación unicelular de esas células T específicas. Y este agente muestra marcadores potenciales de beneficio y de resistencia. En este caso, el receptor IL-7, que parece que es un predictor de falta de respuesta a nivolumab en estos pacientes en enfermedad temprana. Y eso se puede traducir en enfermedad metastásica también. Hay varios estudios fase 2, ya sea con monoterapia, con anti-PD1, PDL1 o una combinación de inmunoterapia que se han realizado y resalto algunos de estos con los círculos. Arriba ven nuestro estudio que tenemos PCR 15% y 45% en la tasa. Más abajo tenemos cuando se vio el anti-PD1 sintilimab, que muestra resultados muy similares y otros han demostrado menores tasas. Y el estudio de NSCLC en el Start, ese que se hizo en el MD Anderson, el doctor Gastonian y colegas mostraron que la relación PCR 9% con nivolumab solo contra 29, con la combinación de nivolumab, cetuximab. Sin embargo, esto fue a costa de mayor toxicidad. Entonces, cuando se utilizan los dos, se crea más toxicidad que uno solo, pero esto también puede ser un poco prometedor. El doctor Prevencio y colegas de España también realizaron este estudio ADIM, que incluyó a pacientes con 3A, estadio 3A, y el punto final del estudio era sobrevida libre de progresión a 2 años. Los pacientes recibieron 3 ciclos de carboplatino paclitaxel adyuvante más nivolumab y luego se metieron a cirugía. Postquirúrgicamente los pacientes pueden recibir hasta 1 año de inmunoterapia adyuvante. Y aquí en este estudio 46 pacientes fueron reclutados. Esto era en una población con enfermedad localmente avanzada. 74% de los pacientes resolvieron, más de la mitad de los pacientes tuvieron una multiestadios y esperamos los mismos. Y también la respuesta radiográfica fue 76% y 41 de los 46 pacientes pudieron tener una resección R0. La mayoría de los pacientes, 80%, redujeron su estadio. Y PFS, este es un estudio de población 3A, fue prometedor, 77%. Quizá lo más impresionante fue la respuesta patológica completa. 57% de los pacientes tuvieron una respuesta patológica completa. Hay varios estudios fase 3 que se están realizando para ver la quimioterapia y inmunoterapia en adyuvante para los pacientes que tienen cánceres de pulmón, células no pequeñas resecables. Ven ustedes la principal diferencia entre el Checkmate 06 que discutiré y los otros estudios. Los otros estudios incluyeron 1 año de inmunoterapia adyuvante o un control y el Checkmate 06 fue de nada más de quimioterapia y inmunoterapia no adyuvante.
Y aquí está el Checkmate 816. Así que fue un estudio fase 3 aleatorizado con pacientes con cáncer estadio 1B potencialmente resecable, de cáncer de células no pequeñas. Como muchos estudios, se diseñó de acuerdo a la 7ª edición, un poco diferente a la edición actual. El estudio excluyó a pacientes con mutaciones, los pacientes fueron estratificados por estadio, PDL1 y sexo, a un brazo de quimioterapia con 3 ciclos o quimioterapia con platino más nivolumab. La cirugía se iba a dar 6 semanas después de la última dosis de la quimioterapia y postoperatoriamente, como les dije, era quimioterapia o radiación. También hubo un tercer brazo de nivolumab más ipilimumab. Sin embargo, se descontinuó temprano por datos de la enfermedad metastásica, sugiriendo que tal vez la quimioinmunoterapia sería una estrategia más efectiva. El objetivo clínico fuera respuesta patológica completa y sobrevida libre de eventos, ambos evaluados con una revisión ciega independiente, y hubo varios variables y marcadores que voy a mencionar más adelante. El comité no sabía qué brazo o de dónde venían las muestras, de qué brazo venían las muestras y los criterios de respuesta que les describí hace rato. Se publicaron en el Annals of Oncology. El primario y los ganglios linfáticos muestra, y la respuesta patológica mayor se definió como 10% en el primario, en el primario y los ganglios. Esto se evaluó en la población de intención a tratar, todos los pacientes incluidos en el estudio, independientemente de si se operaron o no. La evaluación de biomarcadores incluyó tejido, carga de mutación tisular, y el análisis de ADN del tumor circulante se hizo en un subgrupo de pacientes usando una secuenciación de ctDNA, hasta 200 mutaciones somáticas de los pacientes tratados. Las muestras se colectaron antes del primer ciclo de quimioterapia y antes del ciclo 3, y la depuración de ctDA se definió como ctDA detectable antes de tratamiento o no detectable en el ciclo 3 día 1. Estas son las características basales de los pacientes incluidos con un promedio de 65 años. Los pacientes fueron incluidos en Europa, Asia y Norteamérica. La mayoría de los pacientes, el 63%, tenían estadio clínico 3A. Y esto es diferente al Empire 010, el estudio con atezolizumab, en donde la población tenía 40-45%. El 50% de los pacientes tienen enfermedad epidermoide, un poco más abajo que los estudios de adyuvancia, pero en expresión de PDL1, el 50% de los pacientes tenían tumores positivos. Similar al Empire, esta fue la disposición inicial de los pacientes. Casi todos, 98% en ambos brazos, empezaron la terapia neoadyuvante. Más pacientes, 94%, nivolumab más quimio. Los pacientes completaron los 3 ciclos de terapia, de quimioterapia, y fueron a cirugía. Yo creo que es importante observar que esto es una población del mundo real y son estadios clínicos de cáncer no patológicos. No todos los pacientes se iban a ir a cirugía en estos estudios de neoadyuvancia. 77% de los pacientes recibieron nivolumab y quimio versus 61% en quimioterapia con lobectomía, o sea, un poco más alto, y menos pacientes necesitaron neumonectomías. 16% de los pacientes recibieron nevo más quimioterapia y también tuvieron cirugía. Lo interesante es que menos de la mitad en ambos casos tuvieron progresión a eventos adversos. Otros eventos, los pacientes decidieron no hacerse la cirugía y otros sí, quimio y radiación. Y antes de la cirugía se habló de función pulmonar para guiar a los cirujanos. 1 de 5 pacientes tuvo cirugía antes del último ciclo, pero hubo retrasos por ingresos al hospital. Esta es la respuesta patológica completa, que fue quimioterapia de 2.2 a 24% con nivolumab y quimioterapia para una razón de momios de 15.4, y esta es en la población independientemente de si tuvieron cirugía. Del lado derecho vemos a los pacientes con resección, nuevamente resultados similares, y viendo el tumor primario, nada más. Parece que no varía mucho en la evaluación. Del lado derecho, la tasa de PCR en el brazo exploratorio fue 20.4%. Los pacientes en el brazo de nivolumab y quimioterapia tuvieron menos tumor residual en la resección, 10% en el brazo de nivolumab quimioterapia y 74% en el brazo de solo quimioterapia. Lo interesante es que los pacientes estadio 3A tuvieron tumor residual viable en el de nivolumab y quimioterapia versus 70% en el brazo de quimioterapia. El beneficio en cuanto a la respuesta patológica completa parece sostenida en los subgrupos analizados, incluyendo estadio, histología y el estatus PDL1. Y hay que observar que en el entorno adyuvante, atezolizumab parece, o el beneficio viene de los tumores PDL1. Este es un diferenciador potencial entre la quimio neoadyuvante versus la IO adyuvante. En cuanto a la estratificación radiográfica, todos tuvieron respuestas radiográficas en el brazo de nevo más quimioterapia, 54 versus 37%, y más pacientes tuvieron respuesta radiográfica. Más pacientes en el brazo de nivolumab más quimioterapia tuvieron cirugía, recordando que 63% tenían enfermedad 3A y menos pacientes necesitaron neumonectomía. 30% en el brazo de quimioterapia. Hace rato les dije que el ctDNA, muchos en este análisis de su grupo tuvieron depuración de ctDNA en asociación con la respuesta patológica, y entre los pacientes que recibieron o que tuvieron esta depuración, más de estos en el de nevo más quimio, tuvieron una PCR con depuración de ctDNA. Los eventos adversos no aumentaron agregando nivolumab y quimioterapia, y los eventos adversos fueron bajos. Solo 2 pacientes en todo el grupo tuvo neumonitis y eran eventos de bajo grado. Resumiendo, el Checkmate 816 mostró una mejoría en la variable de PCR, casi una mejoría de 40%. Esto fue consistente en todas las histologías, expresión de PDL1 y TMB. El estudio sigue avanzando para evaluar el sobrevida. Agregar nivolumab a quimioterapia fue tolerable y no aumentó la posibilidad de cirugía.
More frequent with nivolumab plus chemo compared to chemo alone, and may be associated with pathological complete response. So this is the first of several phase 3 trials, I think, which aim to assess the benefit of neoadjuvant immunotherapy plus chemo, and it's encouraging that at least for the PCR endpoint, it's positive. In summary, so adding PD-1 blockade to neoadjuvant chemotherapy increases radiographic response, may allow more lung-sparing surgery, and appears to very significantly increase pathological complete response without increased toxicity. Neoadjuvant clinical trials, I think, especially in the phase 1 and 2 setting, offer an exceptional platform for translational research, with opportunities for us to explore ctDNA dynamics, genomic determinants of response, and indeed functional immune responses, which could inform both early stage disease and metastatic disease. And I think, as we'll see from colleagues discussing adjuvant therapy, I think this will be a mainstay of perioperative management for the near future for clinical stage 2 and 3A non-small cell lung cancer. Thank you for inviting me. I'm looking forward to discussing further.
Hola, ¿qué tal? Muy buenas tardes a todos. Pues,
good afternoon. I would like to thank the organizing committee and especially Dr. Francisco Corona for inviting me. I'm thankful for being with great experts to talk about the new strategies of systemic adjuvant treatment in non-small cell lung cancer that is resectable. And very quickly, I don't have any conflict of interest. I would like to talk about 3 important things today. What we know to date that has been implemented in the daily care of our patients in terms of adjuvants, what we're trying to improve, and the different options and therapeutic strategies, and especially what can we use in the near future when we want to talk about biomarkers. So to date, What we have in our clinical practice is adjuvant treatment or chemotherapy with platinum because of three things. Number one, because of the benefit in decreasing the risk of recurrence or of death from lung cancer, with a benefit in this disease-free period of up to 16%, the benefit in the risk reduction of death of about 11%, and the benefit in the overall survival at 5 years that is very low, unfortunately. We're talking from about 4 to 5%. That's the benefit we have today when we use adjuvant therapy. Another controversial issue, but I think it has been installed in the clinical practice, is to decide what to do with our patients in clinical stage 1. Although we know the patients in studies are in 1B stage or more than 4 centimeters, many trials, and something that I appreciate is that academic studies from different worldwide institutions have tried to show that patients in stage 1 that have had radical resection, but with high risk of factors such as vascular invasion, lymphovascular invasion, and to the visceral pleura, and also controversial, some people take into account tumor size after 2 centimeters. There is a benefit in the overall survival when they receive adjuvant chemotherapy. And this is something that has been done in the past few years to benefit more patients, and especially give them a significant benefit in the overall survival at 5 years versus the patients who don't get adjuvant therapy. Another interesting thing is that patients in the metastatic context have had a survival benefit, and that has been achieved is stratifying the disease with different biomarkers. This is how we change the history of patients with advanced disease, and I think today it's the only way we're going to select patients better for adjuvant therapy. And obviously we can't ignore the study Adaura with osimertinib, with a mutation that showed a benefit in reducing the risk of death or recurrence of 79%. These are impressive values with a disease-free survival rate of 86% versus placebo 53%. Regardless of whether the patients had used adjuvant chemotherapy or not, and regardless of the clinical stage of the disease. This is important because we want to benefit the EGRF mutated patients. That's between 11 and 35%, depending on the type of population where we find these mutations. But these are data difficult to improve in the future with other EGFR studies, as I will show you. So how is the strategy changing? Well, because of an unmet need. That is the high rates of recurrence that we see in these different stages of the disease that obviously increases the risk of recurrence depending on the disease stage. And because of the poor benefit of only giving adjuvant therapy at 5 years, which is 4 to 5%. So the strategy today is to use the tumor genotyping so that we can change the therapeutic algorithm and use targeted therapies. However, there are many questions that I ask myself every day with my from my patients. Will this targeted therapy fulfill the unmet needs of our patients? Can we treat patients earlier? And will that make patients live longer? How long do patients have to follow treatment? Studies have different strategies, 1 year, 2 years, up to 3 years of adjuvant therapy, as we saw in the study. Adjuvant chemotherapy will have to be a requirement to then continue with targeted therapy. And what are we achieving? Well, will patients be cured, or do we have late recurrences? This is also very controversial. Why? Because most studies, specifically talking about targeted therapies, tyrosine kinase inhibitors in adjuvants, the primary endpoint is disease-free survival and overall survival. So regulatory agencies are accepting the primary endpoint of progression-free survival. But we do want to see the overall survival. That's why we have like a bittersweet feeling when we look at the studies of these tyrosine kinase inhibitors in adjuvants. Because when we look at the overall experience, we don't see positive results. We will have to wait for more information, such as the global data, survival data. And new strategies, not just talking about adjuvants, for patients with tyrosine kinase inhibitors. Why not talk about the trials that are carrying out neosurgery strategies and adjuvants with tyrosine kinase, such as the emerging trial that used ergotinib for 42 days versus 2 cycles of chemotherapy, and then patients were operated on, and then continuing erlotinib until there was disease progression versus 2 more cycles of chemotherapy. We see it's a positive trial because there are higher response rates, but going back to the same question, when we look at the overall survival results, we're not getting the results we would want as clinicians to think that our patients are living longer with these new strategies. What are we achieving, not just with the therapeutic options, but with the strategic options? And we have to talk about immunotherapy in adjuvants. The different studies that have been carried out by using PD-1 inhibitors or PD-L1 inhibitors. The main objective is progression-free survival. And others question data such as what happens in patients who have a who are PD-L1 positive. I will talk about the EMPOWER. It's a study that, well, we've seen it in the past 3 meetings in ASCO and the lung Congress with different results and with information showing that immunotherapy as adjuvant is something that could change today the treatment strategy, specifically talking about patients who are PD-L1 positive with more than 1% of expression. And in stages 2 and 3, because of the type of hierarchy study that we will see in the next few years, because we have to look at the results of the intended to treat population, and because we're going to have to look at the overall survival data. However, we see that after 4 cycles of adjuvant chemotherapy, giving patients atezolizumab for 16 cycles could be interesting, not just for PD-L1 positive patients, but for the time being, this is the information we have, and I think this is my opinion, that these are the patients that benefit most. We're just selecting patients better. So we're getting 50% more of these patients that express PD-L1 in this trial. I think there are more factors that affect the response to neoadjuvants. With no benefit in the EMPOWER, we see patients who are PD-L1 negative. The type of surgery has something, we had to take that into account. Patients who have pneumonectomy don't benefit with this treatment strategy, and patients with an EGFR or who are ALK positive, and some of them have a benefit because we haven't seen the data. We have to wait for these. And those that benefit most are the ones that overexpress PD-L1 and those who have an expression above 50%. Patients who had a lobectomy and that complete 4 cycles of adjuvants. It's important to see that biomarkers that is measuring PD-L1 is done in the tumor as such, and we're not looking at micrometastatic disease. That's important. The host factors affect the pharmacokinetics, the microbiota, the ADAs, the T cells of each patient, and questions that come up, you know, for example, what's going to happen to these patients? Are they going to have a first line of immunotherapy? What's going to happen with patients who develop immunomediated adverse events if we want to re-challenge them in the future? And especially the question that remains is to see the overall survival data, because we don't know if we'll be able to see them. Hopefully we can. What do we see? Well, what Dr. Ford said, and I don't want to be redundant. I just want to talk about the questions that emerge as to the strategies the new strategies. So what's better? To use the entire treatment, and that is neoadjuvant, surgery, and adjuvants, or just neoadjuvants? What's going to be better? The data are pretty exciting of the CheckMate 777, and this is a phase 2 showing 2 important targets. And it's not just the controversy of using complete pathological response or major pathological response that fulfills different criteria, as Dr. Ford said. And in these trials, there are better response rates with the neoadjuvant strategies of combining immunotherapy and chemotherapy. But we have to look at the other strategies, and it's just, for example, just using a neoadjuvants like the CheckMate 016 says, where we see Nivo plus chemo versus chemo, and taking patients to surgery, and then looking at the optional adjuvant treatment of chemo plus radiotherapy. What questions arise in this CheckMate trial? Well, when we give neoadjuvants, what is the percentage of patients that don't get to surgery? In the Nivo and chemo group, it's 16%, and in the chemotherapy group, it's 21%. And that, you know, makes us concerned, because what's going to happen with the patients that don't get to surgery? And this is the controversy. What is the best strategy? If we think of neoadjuvants, it's better to treat the primary tumor when we have immunotherapy or immuno plus chemo strategies. Why? Because the idea is that with the tumor in situ, we can trigger or activate the immune system and activate the possibility of cure. That's important. The patients that don't get to surgery, it's a question that we have to ask ourselves. That will this surgical procedure change? Apparently not, but it's also a question that the surgical team has. Is 4 cycles enough? Do we need to give more or less treatment? And is this complete pathological response a surrogate of the disease-free survival and overall survival? And why not think of adjuvants? What's better? Is it better to treat the disease with less tumor burden? The number of patients who, after a surgical event, can finish adjuvant treatment is something that we're concerned about. So patients will be eligible to finish treatment. Treatment compliance, you know, is different, and the duration of adjuvant treatment. Will 1 year be enough with immunotherapy, or do we need more? And also, will the disease-free survival will be the result of the overall survival? We have to wait for the data. And sometimes it's difficult to wait when we have patients to treat in front of us. And the 2 groups, I end with biomarkers. Yes, it seems that in neoadjuvants, we can look for the biomarkers, but what happens with these new biomarkers? It's not so distant. They're not in the distant future. These are interesting. These are original papers presented recently. These are the interaction rates between PD-1, PD-L1, and activation of T cells. the researchers did an interaction, or they scored the interaction. And this is interesting because the higher the score of the interaction, there's a greater benefit of those patients who receive chemotherapy. So this is interesting because these calculations is, or these genome signatures that we use, for example, in breast cancer that helps us select patients who will really benefit from adjuvant treatment is what we need in our patients with lung cancer. Something that predicts who will benefit from this adjuvant treatment and which patients shouldn't take it, such as those who have a poor interaction like this interaction score. It's interesting to see the circulating tumor DNA, or the ctDNA, that we see in different neoplasms, especially for lung cancer. The detection of molecular disease can be used to stratify the post-surgical risk and the possibility of early recurrence to decide whether the patient should receive adjuvant treatment or not. So what do we see in this follow-up? These are serial follow-ups every 3 months of the ctDNA. Post-surgically, patients who have ctDNA, the prognosis is worse. Patients who receive adjuvant chemo may improve this worse scenario. And something interesting is that patients, for example, what you see in the last chart, in the light blue, the patients who don't have a ctDNA, who don't get adjuvant chemo, have a good scenario. So this circulating DNA can help us select our candidates better, and so that they can get the benefit of adjuvant treatment, but not, for example, those who don't have the ctDNA and don't receive adjuvant treatment, and the prognosis seems to be pretty good for them.
Conclusion, what we know, what we have implemented in a daily care is that surgery is the best treatment, and that we can improve just a little global overall survival by adding adjuvant chemotherapy based on platinum. What are we trying to improve? Targeted therapies, for example, using osimertinib for CR mutated patients, or atezolizumab gives 30–40% of patients out of the therapy options, so we have to standardize. Undoubtedly, these treatment options will be challenging to be personalized and to be standardized in the best way possible. What can we use in the future, in the near future? Well, definitely we need to design initial treatment based on the patient characteristics, and the subsequent treatment based on the tumoral response. This is what we need to think of today, and we need to demonstrate the benefit of these new strategies in overall survival. We need to continue to be ambitious with the well-being of our patients. Thank you for your attention.
I want to thank you very much for the opportunity today. I'm going to be going in a little bit of a different direction, talking about pulmonary metastatic disease in terms of indications and future directions when it comes to pulmonary metastasectomy. For patients who have extrapulmonary primary malignancies, the lung is the most frequent site of metastatic spread, with the most frequent sites being of origin in colorectal cancer, sarcoma, melanoma, head and neck cancers, breast cancer, and tumors of the urinary tract, with numerous other malignancies known to additionally spread to the lungs. Historically, systemic therapy has been considered the standard of care for stage 4 disease, given the systemic nature of the malignancy. However, the use of local therapy for metastatic pulmonary nodules is expanding, with substantial evidence for efficacy in terms of optimal local control for prolonging life, delaying recurrence, and enabling patients to experience freedom from chemotherapy. With regard to the benefits of surgery for pulmonary metastatic disease, the existing literature can be challenging to interpret, given the broad heterogeneity of the populations included, spanning numerous histologies, extensive disease burden, and types of treatment. Even focused series tend to have vast differences among patient outcomes related to the type of surgical resection, the margins that are achieved, and the presence or absence of extrathoracic disease. Although it would be inappropriate to offer surgery to all patients with pulmonary metastatic disease, it's well established that there are substantial benefits to selected populations of patients. In addressing the role of pulmonary resection, there are several highly relevant questions that I think must be considered. First of all, is the disease biology appropriate for local therapy? What is the optimal timing for providing local therapy to the patient? Third, what is the most suitable local modality for treating the patient? And fourth, is the patient an acceptable candidate for surgical intervention? Pertaining to disease biology, it's known that certain tumor histologies have a tendency to lead to prolonged disease-free intervals after resection, whereas others tend to occur quickly. In general, the demonstration of disease stability and absence of extrathoracic metastases are well accepted as factors that are associated with better outcomes after pulmonary resection. Further, the ability to completely eradicate all sites of disease is a particularly important consideration with regard to surgical interventions. Finally, it's relevant to consider that some tumors have alternative management strategies that are well tolerated by patients, such as those who could be managed by oral hormonal agents, whereas other diseases may be treatable only by highly toxic chemotherapeutic agents or may not even be treatable with systemic drugs at all. All of these elements of disease biology are pertinent to the discussion of offering patients local therapy such as surgical resection. The optimal timing and sequencing of surgery are both imperative to ensure successful patient outcomes. In some circumstances, patients may benefit from upfront systemic treatment to reduce their tumor volume, which may increase the likelihood of an R0 resection and or reduce the amount of parenchyma required for resection, as well as provide insight into unclear disease biology. However, if tumors are particularly responsive to systemic therapy, small sub-centimeter nodules might become difficult to localize, both radiographically and intraoperatively on palpation. Moreover, there are risks and side effects of systemic therapy which must be considered. The interplay of systemic therapy with local therapies is an important component of the multidisciplinary discussion when we're talking about potentially offering patients resection. While limited studies have delved into this relationship between surgery and systemic therapies, it is the subject of a current ongoing trial in lung-limited metastatic colorectal cancer originating at our institution, which I will discuss a little bit later. There are a variety of modalities available for treatment of pulmonary metastases and numerous considerations guiding the applicability of each of these modalities. Ultimately, for some patients, there may be an obvious best approach, whereas for others, there may be multiple reasonable strategies. Still yet for others, complete local control of pulmonary metastases may best be achieved with a hybrid approach, which I'll also discuss a little bit later. This may require surgery in combination with other strategies, such as ablative therapies, including stereotactic radiation, cryoablation, or radiofrequency ablation. As with surgical interventions for any medical condition, we need to consider not only the best way to treat the disease, but also whether the patient is an appropriate candidate for the treatment. For pulmonary resection, one must consider pulmonary reserve, frailty, and general ability to tolerate both the general anesthetic and the surgical recovery, including nutritional and performance status, and beyond comorbidities, other patient-related factors include social support, compliance with medical advice, as well as emotional well-being. While novel approaches to local therapy have emerged in recent years, surgery has and continues to be the mainstay of local therapy for pulmonary metastatic disease. The predominance of literature supporting this approach has been composed of retrospective reviews. Although variability in patient populations and treatments has rendered a range of outcomes, in general, there's clear demonstration of improvement in prognosis for appropriately selected surgical patients. The greatest volume of data related to management of pulmonary metastatic disease, and particularly related to surgical resection, addresses colorectal cancer. With approximately 1.3 million new cases diagnosed yearly worldwide, colorectal cancer is the second leading cause of cancer-related deaths in the United States after lung cancer. Recurrence of disease after curative resection is the dominant cause of treatment failure, and approximately 1/4 of all patients will have distant disease at the time of diagnosis. The lung is the most common extra-abdominal site for distant metastasis, with the liver being the most common intra-abdominal site. It's estimated that up to 18% of patients will be diagnosed with pulmonary metastatic disease at some point during the course of colorectal cancer. Despite the high prevalence of pulmonary metastatic disease in colorectal cancer, the best management for pulmonary metastases still remains somewhat unclear. We know that in many circumstances, pulmonary metastasectomy can significantly improve survival and may result in long-term cure. As experience has shown impact on survival, operative resection of colorectal metastases involving the lung parenchyma has become a widely accepted treatment strategy for appropriately selected patients. Importantly, with encouraging results demonstrated following surgery, efforts have turned toward elucidating those clinical attributes which render an individual to be an ideal candidate for aggressive local control of pulmonary metastatic lesions through resection. To date, there have been no completed randomized trials evaluating the role of surgical resection in various patient cohorts with metastatic colorectal cancer. And eligibility for pulmonary metastasectomy has been speculated based on a number of retrospective reviews. There's no prospective data evaluating the benefits of surgery in this population, which have been summarized through several meta-analyses and systematic reviews. Consistent among all of these prior series, a longer disease-free interval and fewer number of pulmonary nodules tends to portend a better outcome. Specifically, in a series reviewing our experience at MD Anderson Cancer Center, analyses concluded that greater than 3 pulmonary metastatic lesions at the first metastasectomy and a disease-free interval of less than 3 years predicted recurrence in the lung, while the total number of pulmonary metastases also correlated with overall survival. Further, we found that increasing age and male sex were also associated with shorter survival. The factors of age and sex have been evaluated in other studies with differing results without universal consensus on the impact of these two variables on overall survival. However, a number of large series, including those from our own institution, have repetitively demonstrated consistently that the number of pulmonary metastases will predict survival following metastasectomy. A meta-analysis published by Gonzalez and colleagues in 2013, reporting on nearly 3,000 patients treated with metastasectomy, showed 5-year survival after resection of up to 68%. In this study, the median disease-free interval ranged from 19 to 39 months, with longer disease-free intervals being associated with greater survival, with a hazard ratio for a shorter disease-free interval of being nearly 1.6. Survival was also better among patients without intrathoracic nodal disease or multiple pulmonary nodules, with a hazard ratio for nodal involvement also being about 1.7. In 2016, Lumachi and colleagues analyzed outcomes from 15 retrospective studies, describing a median 5-year survival of 45% after surgery, with some patient cohorts achieving a 5-year survival as high as 72%. This study, as well as a subsequent meta-analysis published in 2018, corroborated the findings that patients with the best prognosis following surgical resection were those who had a longer disease-free interval, who had fewer pulmonary nodules, and absence of intrathoracic nodal disease. So what about the impact of mutational status? KRAS mutations have demonstrated poor outcomes in terms of primary colorectal disease control and for hepatic metastases from colorectal cancer. Less has been known regarding their impact in the lung. Importantly, corroborating previously suggested findings in our investigations at MD Anderson, we found that mutational status was also demonstrated to prognosticate outcome after resection of colorectal pulmonary metastases, in that patients who harbored APC mutations experienced prolonged survival. And in contrast, when we looked at KRAS mutations, we found them to be associated with poor outcomes after resection, with worse overall survival and disease-free survival, shown here in the figure to the right. And you can see that the hazard ratio for overall survival was greater than 3. The hazard ratio for disease-free survival was greater than 2 for these individuals who had KRAS mutations. We also aim to look at the impact of primary tumor location on the outcome after surgery for pulmonary metastatic disease in lung-limited metastatic colorectal cancer. It's well known that patients with primary disease in the left side of the colon have superior survival, and colorectal cancer laterality has previously been implicated in the intra-abdominal local regional disease control, with right-sided tumors having 5-year recurrence rates twice as high as tumors that originate on the left side of the colon. We further identified that an additional prognostic factor for survival after pulmonary metastasectomy relates to the location of the primary colorectal cancer. Patients with rectal tumors display shorter disease-free survival after pulmonary metastasectomy than those who have colon tumors. And at the same time, patients whose initial tumors arose in the left-sided segments of the colon compared to the right-sided segments of the colon tended to demonstrate the greatest survival benefit after lung resection. We also looked at the idea of studies for metastatic colorectal cancer to the lungs. There's a lot of interest in using stereotactic radiation as well as various ablative therapies to treat these types of metastases in the place of surgery. In this study shown here, we retrospectively reviewed patients who were treated for pulmonary colorectal metastases at MD Anderson with SBRT and with wedge resections between 2006 to 2016. This specific study involved 381 patients who had a total of 826 nodules. They were treated, these nodules individually, were treated with 762 wedge resections and 64 courses of stereotactic radiation. And then we conducted our analyses actually looking nodule by nodule. We importantly found an increased risk of local recurrence with SBRT with a hazard ratio of greater than 3. When we did matched weights propensity scoring for local recurrence per nodule, we saw the 2-year risk of local recurrence after wedge resection of an individual nodule to be about 14%. The 2-year risk of local recurrence after SBRT of an individual nodule was nearly 30%, so more than double the recurrence rate that we were seeing after wedge resection. I think these conversations are really important to have in the metastatic colorectal cancer population, as many of these patients may have experienced metastases previously to the liver. And certainly it's tempting to try to extrapolate the outcomes from SBRT or radiofrequency ablation to the liver to the lung, but we recognize that the properties of these tissues are very different, and that we do have the option of providing surgical resection to these metastases to the lung with outstanding outcomes. So ultimately, our conclusion from this study, which was published in JTCVS in 2019, was that pulmonary colorectal cancer metastases that are treated with SBRT have higher risk of recurrence than those treated with wedge resection. And so we would still continue to emphasize the importance of surgery in comparison with these other alternative ablative therapies. Moving on from colorectal cancer, surgery has also been shown to extend survival for patients with metastatic sarcoma. A review by Maruli and colleagues demonstrated 5-year survival ranging from 15% to 51%, so a pretty wide range at 5 years, with tumor histology being particularly important to the likelihood of survival after resection, in that patients who had osteosarcoma fared substantially better than those with soft tissue sarcoma. And among the soft tissue sarcomas, resection of leiomyosarcoma metastases in the lung appeared to have the greatest impact in prolonging survival. Similar to the data for colorectal metastases, patients with sarcomatous pulmonary metastases appear to achieve the best survival after pulmonary resection when they have fewer nodules, longer disease-free intervals, and negative margins at the time of surgery. Surgical therapy has further been found to be beneficial from additional primary malignancies, such as renal cell carcinoma, as well as melanoma. For renal cell cancer, pulmonary metastasectomy has been shown to portend a 5-year survival in the range of 36% to 53%. Again, a pretty wide range. Similar benefit has been demonstrated in melanoma. And again, similar to what we saw with colorectal cancer and sarcoma, patients with pulmonary metastatic disease from renal cell cancer and melanoma also appear to have greater benefit from metastasectomy in the lung when fewer lesions are present, when the disease-free interval is longer, when intrathoracic lymph nodes are uninvolved, and when the surgical resection is complete. With regard to the surgical technique, it's commonly accepted that parenchymal sparing strategies should be emphasized, which contrasts somewhat to the management of primary lung cancer, although we'll hear a little bit more about the extent of resection that's necessary, I believe, from Dr. Stiles, who's speaking after me. The rationale for this parenchymal sparing approach for metastasectomies has been based on the frequent need for resection of multiple nodules, the potential need for future resections or ablative therapy, and the lack of data demonstrating benefit for more extensive anatomic resections, as well as, of course, the expectation of less postoperative morbidity if we do a lesser resection. So thus, the most frequent approach that we see is a stapled wedge resection, whereas lobectomies may be used for larger tumors, central tumors, or in the presence of multiple metastases in a given lobe, where it would actually be less morbid to just do the lobectomy. Of course, it really should be noted that surgical technique is key, with a high risk of recurrence with inadequate margins, which we have shown the exact distance of the margin really does predict the likelihood of the tumor coming back. The optimal operative approach for pulmonary metastasectomy has also been highly debated. There have been a number of studies looking at intraoperative efficacy of thoracoscopy versus thoracotomy, and ultimately showing superior ability to find nodules that are anticipated by imaging on thoracotomy with manual palpation, as well as a greater likelihood of finding and removing additional nodules that weren't even seen on the imaging. Regardless, multiple investigators have failed to show any differences in 5-year survival based on surgical approach, suggesting that it's absolutely fine and appropriate to be operating on these patients with a minimally invasive strategy. Further complicating this issue, it should be recognized that these studies might fail to show survival differences based on the operative approach because again of the inclusion of such widely disparate groups of patients with very different disease biology within these cohorts. So any negative study looking at pulmonary metastasectomy may not truly be a failure of showing a difference, but rather such heterogeneity of the patients in the studies that they're not adequately powered or appropriately designed from a methodologic standpoint to really determine any difference. A recent consensus document emphasized minimally invasive approaches whenever feasible, though ultimately, as it's been demonstrated that the perioperative benefits of thoracoscopy compared with thoracotomy are nearly equalized when enhanced recovery approaches are used, which was previously presented as a Chamberlain paper at the STS. We ultimately feel that the benefits of thoracoscopy compared with thoracotomy in the enhanced recovery setting can be essentially equalized, and the specific operative approach really should be left to the operating surgeon, who can use all of the information based on the number of nodules, their exact anatomic locations, and other patient-specific factors to make the determination about how to make an incision in that given patient. Ultimately, we really do need more prospective data. Using colorectal cancer as an example, throughout multiple retrospective series, decreasing disease-free interval has been shown to be a predictor of recurrence in the lung, and increasing numbers of lung metastases clearly predict worse survival. Nonetheless, we have very limited guidance from prospective evidence. In addition to ambiguity regarding the optimal candidates for pulmonary metastasectomy, there also exists difficulty in determining the relative role of systemic therapy among patients who are being considered for surgical resection. There's uncertainty regarding the interplay between surgery and chemotherapy and their impact on recurrence and survival outcomes for such patients. Ultimately, we see a lot of variability in how these patients are managed in terms of whether they get preoperative chemotherapy, postoperative chemotherapy, whether they are even referred for surgery at all. In terms of the role of multimodality treatment for metastatic colorectal cancer, for individuals with colorectal pulmonary metastases and favorable clinical characteristics, we know that surgery is fairly well accepted. The role of chemotherapy perioperatively, however, for these patients is unclear compared to surgery alone. And again, practices are really widely ranging among and within practice groups, institutions, and regions. For those patients who have colorectal cancer and shorter disease-free intervals or larger numbers of nodules, in other words, those who have poor clinical characteristics predictive of early recurrence, surgical resection in the lung after chemotherapy is oftentimes undertaken if technically feasible, but the additive benefit of surgical resection has yet to be elucidated, and practice patterns, again, are highly variable from institution to institution and surgeon to surgeon. We're also clearly in need of identification of novel biologic prognostic factors. To predict improved survival after metastasectomy. ctDNA is a highly sensitive and specific biomarker collected from plasma, and there are data demonstrating shorter recurrence-free survival for patients after primary colorectal cancer resection if they remain ctDNA positive. The detection of postoperative ctDNA has been associated with shorter time to recurrence compared to those who do not have any detectable ctDNA, and the presence of ctDNA following resection of hepatic metastases, not pulmonary, but hepatic, has previously been shown to be associated with poorer recurrence-free and overall survival. The prognostic implication of ctDNA following lung resection for metastatic colorectal cancer, however, remains unclear, and it really could guide clinicians in the decision to administer postoperative chemotherapy. So the questions which remain as we contemplate the existing retrospective evidence for metastatic colorectal cancer are, number one, do low-risk patients undergoing pulmonary resection benefit from perioperative chemotherapy? Number two, should high-risk patients, so those with a lot of lesions and a short disease-free interval, for those individuals who are undergoing systemic chemotherapy, should they even be offered the possibility of surgery? And three, are there prognostic biomarkers that could better identify patients at higher risk for recurrence following their pulmonary metastasectomies, so we know that they should be receiving adjuvant therapy? These are all questions that we want to sort out and that we've explored with the trial, which I'm about to tell you about. This trial is the role of multimodality management in risk-stratified patients with lung-limited metastatic colorectal cancer. This was activated at MD Anderson in 2018, and it has subsequently been rolled out to the AATS Thoracic Surgery Oncology Group as TSOG trial number 103. The objectives of this trial are shown here. Number one, to compare progression-free survival in patients with low-risk lung-limited metastatic colorectal cancer who are undergoing surgery with or without chemotherapy. So this primary first objective is just to figure out if there's any additive benefit of chemotherapy in these patients who we know are going to do well with surgical resection. The second primary objective looks at the group of patients who are considered high risk, those with a larger number of nodules, shorter disease-free interval, and asks whether these individuals who are already receiving chemotherapy, whether there's a true benefit to offering them surgery, which we know means a significant period of being off of chemotherapy as they prepare for surgery, as they heal from surgery, and potentially time between staged approaches if they have bilateral disease. We also have an exploratory objective to this study, which is to evaluate for changes in ctDNA following surgical resection and chemotherapy in the patients who are enrolled. The stratification for these patients into the low and high risk groups is shown. Those individuals who have a disease-free interval greater than or equal to 12 months and 3 or fewer metastases are automatically considered low risk for occurrence after pulmonary resection. Those who have a disease-free interval less than 6 months or greater than 6 metastases are automatically considered high risk. In addition, we will mention that those individuals who have extrathoracic metastases within 12 months, so for example, a patient who had liver metastases within 12 months would be considered high risk group. The schemata for these two groups are shown here. So again, those in the low risk group are randomized at enrollment to either undergo surgery or stage surgery with perioperative chemotherapy. And those in the high risk group get 3 months of chemotherapy or 6 cycles. And then if they're still resectable, they're randomized to go to surgery at that time or to have additional chemotherapy. I will also mention as one of the factors that helps convince patients who are really eager to have surgery enroll on this trial is that we do have a crossover arm for patients who have stable disease after 6 months who have received chemotherapy to be able to cross over to surgery. We're also checking ctDNA levels at multiple time points. As you can see here, this is in the low risk group and this is in the high risk group. We also have additional stratification within our groups in terms of primary tumor lateralities. So left versus right-sided tumors. And again, we're talking about the left or the right side of the colon, not the left or the right lung, and also by KRAS mutational status. And the rationale, again, for both of these stratifications is, as I explained earlier in some of the retrospective data, in terms of what we've seen for outcomes after pulmonary metastasectomy in patients in each of these groups. Identify optimal candidates for systemic therapy in low-risk disease and surgical resection in high-risk disease. We think this will set the groundwork for future trials in terms of the eventual use of biomarker status to guide treatment modalities, as well as the timing and interplay of multiple modalities of therapy. And with the greatest abundance of literature in the realm of colorectal metastatic disease, there are data that suggest that surgical resection with adequate margins absolutely offers the greatest long-term local control for operable patients. However, I do want to mention that there are other options for local therapy. SBRT has shown some efficacy in a number of different tumor histologies and does show itself to be a reasonable option for inoperable patients who have limited pulmonary metastatic colorectal cancer. For those patients who have extensive pulmonary metastatic disease, the role of surgery can at times be limited by both the extent of parenchyma involved, the patient's PFTs, and the inherent need to stop most immunosuppressive agents for several weeks, both before and after surgery. So again, while we recognize that surgery offers the greatest long-term control for operable patients, we will mention that there is some role for SBRT in inoperable patients, as well as patients who really cannot come off their systemic therapy or can't undergo surgery for other reasons. In these patients who may undergo SBRT, there are also studies that would support the role of SBRT for not only local control, but the potential abscopal effect to improve systemic control as well. There have also been a number of recent reports for percutaneous ablation looking at reasonable local control rates for small tumors, although they still are not as good as our control rates for surgery. These recent reports would support guidelines that encourage us to consider ablation in appropriately selected patients, particularly in combination with surgery. So if there are several lesions that are resectable and others that may not be reachable or may require more extensive resection that the patient may not tolerate based on their PFTs, a hybrid approach may certainly be reasonable. Ultimately, we wouldn't want to undertake any of these approaches unless all disease can be eradicated or if there's truly a palliative reason to be taking out part of the patient's disease. The last part that I will mention is that these types of ablative procedures, again, while they do have higher recurrence than surgery and even higher recurrence than SBRT, these ablative strategies can be particularly helpful for patients who have recurrent disease and are unable to receive any further radiation or any further surgery based on the previous interventions. So in metastatic disease, there are clear benefits to local therapy, and surgical resection in well-selected patients can certainly provide prolonged disease-free survival, as well as enable breaks or even complete lifelong freedom from systemic therapy. It's clear that multidisciplinary evaluation and discussion are keys to identifying the optimal individualized approach for each patient. And based on tumor histology, extent of disease, comorbidities, and alternative treatment options available, the multidisciplinary team can come up with the best approach. Moreover, as novel systemic agents continue to improve our ability to extend the lives of patients with all stage 4 malignancies, has been discussed already by other speakers today, it's expected that greater numbers of patients may experience prolonged survival, and thus increased numbers of episodes of disease recurrences in the lung. And in these circumstances, hybrid approaches really may offer the benefits of all modalities available. Thank you very much for the opportunity to speak today.
Hi, I hope that everybody can see me and see my screen panel, and I've learned a lot, which is always a good marker of a panel. We're going to switch a little bit and talk from the most advanced disease to the earliest stage disease. I think it's a topic, though, that you'll see is relevant to all of us as we're in this increasingly complex world of systemic therapy, immunotherapy, targeted therapy options. And the key is not to miss out on the patients who would potentially benefit from those types of therapies. These are my disclosures. So I always like to start talks thinking back a bit in history, and I think it's important to remember we're having a debate now about lobectomy versus sublobar resection, but at one time there was a debate about pneumonectomy versus lobectomy. And this is Dr. Gilmore, who did the first successful pneumonectomy with his patient. I'm sorry, this is Dr. Graham with Dr. Gilmore, who was his first. I'm sorry, this is Dr. Graham with Dr. Gilmore, who was his first patient. And it's hard to think back to those days where people thought that you had to do a pneumonectomy to get all of the cancer. That was certainly the case. But then later in the 50s, people realized that maybe it's not the operation, but it's more the biology of the disease. As we've become more successful, I think, at identifying biology of the disease based on all the talks that you just heard, I think we can tailor surgery even more. What's remarkable here is it took until then to realize that localized, not localized, it didn't matter. Lobectomy tended to do a little bit better. See some of this here where we can sometimes hurt patients with pneumonectomy, and that's interesting, I think, as we look at some of the newer segmentectomy versus lobectomy data. We still think about need for sublobar resection. Well, certainly we can detect earlier and less invasive lung cancers now. Limited resection is common in other types of cancers. It would, in this case in the lung, it's got the particular advantage of preserving pulmonary function. It may allow for resection of other local treatment or future cancers. And survivable perhaps is comparable to lobectomy. That's always been the question. It's also important to acknowledge that there's other great competing options for patients with early stage lung cancer, and particularly stereotactic ablative radiation therapy. This was just reported at ASCO this year from Dr. Antonoff's institution. Really caught a lot of headlines. We have seen SBRT survival curves in the past that have gone down rapidly based upon the disease that patients have or their competing comorbidities. But this group really showed that in healthy patients, SBRT could be associated with remarkable long-term overall survival. And I think clearly we have to do better as surgeons, given that the bar has risen higher and higher with other treatment modalities. So it's also important to say, well, we've been here before. We've been talking about lobectomy versus sublobar resection, either a segmentectomy or wedge, for quite some time. The famous lung cancer study group trial published in 1995 suggested that limited resection was inferior to lobectomy. You can see the survival curves there. And for quite some time, that mandated that lobectomy was the standard of care. That said, we saw many institutional series suggesting equivalence of sublobar resection. And there were many criticisms of the lung cancer study group. Tumors allowed were up to 3 centimeters in size, and maybe 2 centimeters should be the threshold. There were a lot of wedge resections. This was before PET scans. We weren't nearly as good at staging patients and identifying occult metastatic disease. Sample size was small, and after all, if you look at the p-value, it didn't prove that the survival differences were not significant or were significant. Now, just this year came the remarkable results of the JCOG 0802 study. This was presented by Dr. Asamira at AATS in 2021, virtually again, unfortunately. But this is really probably one of the most important surgical trials in quite some time in the lung cancer space. This was a randomized trial of segmentectomy compared to lobectomy, and that's going to be important to point out the difference with the North American trial. This was segmentectomy for peripheral non-small cell lung cancer. Here's the study schema. It was stage 1A, as we talked about. Importantly, in Asia, obviously, there's a lot of part solid tumors, and so tumors had to have a consolidation to tumor ratio greater than 0.5. You see the different characteristics, and this is over 1,000 patients. And this trial enrolled very quickly and was very expertly done. The primary endpoint was overall survival, and you see the secondary endpoints there. And this is the meat of it. I'll show some of the other data last, but this is really what popped out and I think surprised a lot of people, that not only did they find they were equivalent, but this even suggested that overall survival was slightly better with segmentectomy. And again, a very well-powered study with large numbers of patients in each arm. Remarkable 5-year overall survival for stage 1 lung cancer patients, 94% in the segmentectomy arm, 91% in the lobectomy arm. You know, arguably a new standard of care for surgical therapy of stage 1 lung cancer, and certainly makes the case that surgery still should remain the primary treatment modality for these patients. Now, it gets more interesting when you start to tease out the data, and I should say that this has not yet been published. I'm told that it's been accepted in Lancet, but I have not seen it yet. And so these are some of the slides from the data that was presented at AATS. And this is what kind of got people talking, I think, and slowed down the publication, I think, to work out some of these details, but it's interesting to go through. Probably as expected, local regional recurrence was greater with the segmentectomy than lobectomy. That's similar to some of the data that Dr. Antonoff just showed with surgery versus stereotactic radiation. We know that lesser resections, we would expect to see higher local regional recurrence. And if you tally up all the local recurrence, 10% in the segmentectomy arm versus 5% in the lobectomy arm. But those local recurrences, as I mentioned, didn't translate into survival differences. Lung cancer deaths were no different. We've got all these great therapies that you've heard about for patients whose disease advances or progresses, but other causes of death, including second lung cancer or higher in the lobectomy arm, I think that puzzled several people. But there was also some mortality from non-malignant disease, again, raising the question, and it was a small difference, but raising the question, at least amongst the discussions of this paper, whether there's more physiologic effect to lobectomy than perhaps we thought. Is here that indeed, if you look at the pulmonary function tests, which were a secondary endpoint, with a lobectomy at 1 year, patients lost a median of 12% of FEV1 compared to 8.5% for segmentectomy. So clearly statistically favoring segment over lobectomy to preserve lung function. But the difference was, I think, arguably much smaller than many people expected, only 3.5%, which if one looked at calculated differences, this should be much more significant. Really, when it comes down to it, it wasn't as big of a difference here. So is segmentectomy the new standard? I think it's difficult to say, and certainly we should at least wait until the paper comes out. I do think that questions remain regarding the biology of cancers and the biology of cancer, lung cancer in Asia, early stage lung cancer may be different. They may find lesions more early that may be arguably more, I don't like the word indolent, but perhaps more of an indolent biology. It's important to point out that CLGB 140503 still needs to report out results. I think regardless of these two trials, sublobar resection is here to stay. Other competitors in the treatment landscape are lung preserving. I told you about stereotactic radiation therapy, but increasingly we're seeing more and more ablative technologies coming down the pathway as we get more sophisticated with our interventional pulmonary tools. So how will we interpret the role of wedge CLGB 140503? And I think we'll be able to better answer the question of standard. It's important to point out that as opposed to the JCOG study, the CLGB study allowed wedge resection, and surgeons sort of voted with their feet here. You can see that 58% of resections in the CLGB study were wedge resections compared to segmentectomies. And so clearly in North America, that seems to be perhaps a preferred strategy. Whether that will lead to a difference in results, we shall soon see. So I think regardless of where we are and what the data shows, what else affects quality of sublobar resection? Are there times we should or times that we shouldn't? I think are important topics to tackle. Certainly, we know that there's tumor factors, and you've heard from the other speakers about all the things that we know about tumors now. The ones that influence me for sublobar resection are size and location, radiologic features, and histologic subtype. But there's also surgeon factors, and I think predominantly preoperative staging. We've got amazing staging tools now. We need to use them to make sure that we can identify patients who are eligible for these therapies that Dr. Ford, Dr. Garcia talked about. But other factors that are important are surgical margins, lymph node dissection. I'll start with talking about the surgeon factors because I think they're a bit easier. We know that margin matters, and that's probably impacts local recurrence rates for stereotactic radiation and other things. There's been lots of papers showing that margin matters, and the size is somewhat variable, but many have settled around this idea of 1 centimeter, and that an idea in this analysis of several series suggested that a margin to tumor diameter greater than 1 reduces the recurrence rates. The optimal margin probably varies, and it probably depends upon the histologic subtype. And it may not be as important for part solid tumors where less of a margin may be just fine. Lymph nodes matter, increasingly lymph nodes matter. And that's something that I like to preach and I think surgeons should preach. We have to sample lymph nodes adequately so that we can identify patients eligible for therapies that we have. But also there's a survival advantage, whether that translates to stage shift or whether there's a true survival advantage or whether patients with more lymph nodes tend to do better. We still need to tease out. This is data from SEER that shows if a wedge resection is done, there's a survival benefit for each node number category as you go. You take more nodes, you get better survival. That may speak to different surgeon influences, surgical volume, things like that, and to be teased out, but others have shown similar things. Our group looked at SEER Medicare, which is a similar database, and we showed that a more extensive lymphadenectomy can overcome the detrimental effects of sublobar resection on survival seen in that database when you compare sublobar resection to lobectomy. I think somewhat startling here, and this should catch everybody's attention, if you look in this database at lobectomy versus sublobar resection, only 5% of lobectomies are reported without any lymph nodes, but almost half of sublobar resections are. So clearly showing that we need to do a better job as surgeons to at least sample lymph nodes. And you can see it goes up progressively. The number of patients who get more than 10 lymph nodes sampled in a sublobar resection is sadly quite small. These are the survival curves from that study. And you can see that unmatched patient populations, patients with sublobar resection do worse than lobectomy. As we've talked about, the same is true for cancer-specific survival. If you match the patients to try to account for different characteristics of the patient, there's still a detriment to sublobar resection in this database. And again, it's hard to account for sort of treatment allocation bias in these types of studies. But if we looked at patients who were matched who had any nodes sampled, those survival curves start to get a little bit closer and start to overlap. And if we look at those patients who had greater than 9 lymph nodes sampled, what we would consider to be standard and optimal in lung cancer, then the survival curves overlap. So that would suggest that a sublobar resection with adequate lymphadenectomy may be the equivalent of a lobectomy. Was there any prospective suggest that sublobar resection gets better margins and more lymph nodes? This trial is ACOSOG, the Z32 study, and it wasn't designed to answer that question. It was really designed to evaluate the role of brachytherapy with limited resection. But it provided an interesting window to look at segmentectomy, 57 versus 153 wedge resections, and specifically to look at those questions that I asked. And you can see that here. These are same surgeons doing either segmentectomy or wedge. If you look at the nodes, there was upstaging in 9% of the segmentectomy group, just 1% of the wedge resection group, hazard ratio of 10 for that. So we do better staging, we do better identifying patients eligible for adjuvant therapy if we do a segmentectomy and get more nodes. Similarly, if you look at margins, adequacy margin 1 centimeter or more was achieved in 70% of patients with segmentectomy versus just 44% with wedge. So segment does better with margins, does better with lymph nodes. And is there any high-level evidence for survival? Well, prior to JCOG study, there was not. There were a handful of meta-analysis that at least suggested that there was an advantage to segmentectomy versus wedge rather than versus lobectomy. This was an assimilation of several studies that had tried to look at that and suggested that segmentectomy was associated with better survival than wedge. Again, a bit difficult to account for treatment bias in these types of studies. Well, so where are we? Well, wedge resection as a general strategy is likely worse than segmentectomy. However, a tailored approach might be appropriate in some patients, and the success of any sublobar resection likely depends on our ability to correctly predict tumor biology. Increasingly, tumor biology can be predicted radiographically. There's been a series of incredible trials from Japan, really, talking about radiographically determined non-invasive or poorly or minimally invasive adenocarcinomas. If the consolidation to tumor ratio is less than 0.5, the 5-year overall survival with lobectomy is remarkable, 97%. 10-year recurrence-free survival, 84%. For sublobar resection in JCOG 0804, this was defined as adenocarcinomas less than 2 centimeters with less than 0.25 consolidation of tumor size ratio. And these were predominantly wedge resections, 5-year recurrence-free survival of 99.7%. You can ask if all these tumors needed to be removed, and I think the answer is no. But I think clearly shown that if someone does make the decision to remove these types of tumors, it can be treated with a limited resection, potentially a wedge resection. We know that any ground glass component may portend a better prognosis. It leads to a benefit of at least 20% in recurrence-free survival. It's been shown by many authors. And I think this data, though, does call into question of how do we apply the JCOG study, the limited resection segmentectomy versus lobectomy, to these types of tumors. And we're still awaiting data on what proportion of tumors in that study had a ground glass component. There may be other metabolic predictors of biology as well, and we get PET routinely as the staging for these patients. This is a study from Sloan Kettering, patients undergoing limited resection. Patients who had that low consolidation to tumor ratio had no recurrence at 5 years. You see the straight line going across the bottom there. Patients with high consolidation of tumor ratios could be stratified by SUV-max based on the median. Those with higher, more metabolically active tumors were more likely to recur, and so maybe are not good candidates for sublobar resection. We had looked at similar things previously and talked about the SUV to tumor size ratio. The idea is that some small tumors, although not PET avid, because the ratio is so high, those may be metabolically active. And remarkable, if we saw the highest quartile of that, so the SUV max to tumor size ratio is greater than 3.2, there was a 30% risk of lymph node metastases for us in those patients. Obviously not good candidates for limited resection, even in some tumors with a very small size. Histology may also predict the success of sublobar resection. The Sloan Kettering group has written a lot about micropapillary components, that the 5-year recurrence with a micropapillary component higher than 5% is markedly higher with sublobar resection, 34% versus 12%. That can be educated by lobectomy. So micropapillary doesn't appear to affect local recurrence when lobectomy is performed. And this is a graphical representation of the cumulative incidence of recurrence based upon the percentage of micropapillary tumor. And that data has now been replicated by others as well. And others have talked about STAS, or this concept of spread through airways, free tumors that kind of break off. We always wonder as surgeons, how can we have a recurrence when we had a negative margin? And this is the idea of that maybe in some tumors, there's the existence of these cells in the airway nearby that may not be accounted for by the growth pathologic margin. This group found that there was much higher incidence of local regional recurrence with limited resection, in particular if there was STAS, which seems, again, makes sense. Other groups and groups from Japan have defined the same thing. STAS is sort of a moving target, though. It's interesting, though, and then it's being used in some adjuvant studies I know now to try to define patients at risk for recurrence, particularly stage 1B patients. So our own real-world practice at Cornell, where I was previously, we looked at segmentectomy versus wedge resection. And you can see the different criteria for entering patients into it. Some of these were not able to tolerate lobectomy. Some were purposeful limited resections. And there were advantages to each. I think we could be faster with wedge resection, even though we had more frozen sections. Patients had less pulmonary complications with wedge resection. But again, we got more lymph nodes. Lymph nodes were assessed in 95% of segmentectomy patients, just 70% of wedge resection patients. The bottom line for us, though, is that with carefully selected patients, we could get equivalent survival with segmentectomy and wedge resection. In our hands, we didn't see an advantage. But again, that's pretty carefully sort of thinking these patients through and trying to select them appropriately. Interestingly, tumor SUV max was the one significant hazard ratio for prediction of recurrence in these patients. One final caveat, I think, is we increasingly turn to screen-detected cancers. The question whether the unique biology of screen-detected cancers, whether that's different from a cancer that's found in other methods, or these more slower-growing, more indolent, again, type tumors that can be detected by screening, could those be candidates for sublobar resection? Obviously, this is going to generally be a younger patient population, but also heavily at risk for other primary tumors, and so limited resection may be appropriate. Our group looked at the National Lung Screening Trial data and found really no difference between sublobar resection and lobectomy in the groups that were treated as such, about 1,000 patients treated surgically in that trial. So in conclusion, I think the surgeon's ability to accurately stage and provide optimal local control, surgery is the ideal local therapy option for most patients, and particularly the staging aspect, given our ability to deliver outstanding therapy to these patients now. With JCOG 0802, I think, and regardless of the CLGB study, sublobar resection is certainly here to stay. I think segmentectomy may be the new standard of care for patients with tumors less than or equal to 2 centimeters, and certainly in Asia. I think we'll have to wait and see how that can be applied to North American or to other patient populations where the proportion of patients with tumors, with solid tumors may be higher. Imaging and histologic characteristics can certainly help to predict appropriate patients for sublobar resection. Wedge resection, I think, is associated, we know it's associated with less lymph node sampling and closer surgical margins and should probably not be the uniform procedure of choice for most patients. However, wedge resection may be appropriate for carefully selected patients. Thanks, Dr. Corona Cruz, for inviting me, and thanks for having us. I'm looking forward to the discussion.
We'd like to thank the speakers. We have just a few minutes for the Q&A session. The first one is specifically for Dr. Antonov. In the current scenario, is systemic therapy, new systemic therapy, or is there a place to consider pulmonary metastasectomy as an option for patients?
I'm sorry, I'm not sure that I heard the entire translation. The question was, is there a role for pulmonary metastasectomy?
Yeah, the question is, in view of the actual successful systemic therapies, is there a role currently and in the future for the metastasectomy?
Absolutely, yes. I think we have a lot of compelling data to tell us that there certainly is a role for metastasectomy. We know that, in general, we think of systemic therapy as, being a really not a curative treatment. And even in patients in whom it can, even if we have novel systemic therapies that can lead to prolonged periods of time without development of new metastases or growth of lesions, it is not handling the disease at a local level. And ultimately, we also know that a lot of these tumors eventually develop resistance and patients develop adverse effects and they get fatigued of it. So if we can provide patients with definitive local therapy that gives them freedom from future systemic therapy so that they can put their cancer diagnosis in the rearview mirror, I think we're doing them a great service.
Completamente de acuerdo, creo que.
Yes, I agree. Far from, being delayed. Your talk showed clearly that the surgeon has to be involved in the research, of the role of surgery in this multidisciplinary team. Thank you, doctor. We have another question for Dr. Stiles. What is the profile of the patient that is considered for segmentectomy and not for lobectomy?
Great question. I think it still is a moving target. If the CLGB study shows equivalence between segmentectomy and lobectomy, I think that there may not be a profile. I think that it'll be any tumor less than 2 centimeters peripheral will be considered and would be considered potentially standard of care across the world or country. That's different for me, though. As I sort of mentioned, I think about histology. I think, is there a micropapillary component? Does the tumor have a high PET SUV? Those might dissuade me from segmentectomy because I know that those patients are at risk for occult nodal disease. We're getting better and better techniques to identify those patients, as Dr. Garcia, Dr. Ford had described. But I think right now, pathology is still king for surgeons with early stage disease. And so I think lymph node dissection, identifying those, and lobectomy makes sense in those types of high-risk tumors, which we'll continue to better define. Maybe ctDNA will take the place of some of these as we move forward, though.
Una pregunta que no va dirigida a nadie, pero preguntan.
Y aquí no se oye. The major pathological response in case of new adjuvant treatments, is that the best measure? Or as Dr. Garcia said, should we focus on the ctDNA as a predictor of how successful our systemic treatment is?
Esta, si quieres, Paco. A mí me parece que vamos a tener que utilizar
I think we're going to have to use different strategies. I think that is the most interesting thing we have today, and use these different tools. That's going to be very important. As you said, and as my colleagues said, as a multidisciplinary team, we have to know exactly what we're doing, not just medical oncologists in our area, but the surgical team has to definitely be on board with us. Sometimes we don't know what the surgical consequences are, and that's the benefit of the multidisciplinary team. So we have to include pathologists. Well, we have for many years, but they are now talking to us on how they are measuring the complete pathological response, a major pathological response, what are the strategies we're going to use, and definitely molecular biologists have to be an essential part of this team for the ctDNA.
May I ask a question just as a follow-up that maybe Dr. Garcia or Dr. Ford could ask? For ctDNA, certainly I think we can think of it as predictive of systemic disease, but are either you aware, does it predict response to neoadjuvant or adjuvant therapy? It may predict the need, but do you think it will predict response? And the neoadjuvant setting in particular.
Creo que es algo muy interesante que podemos hacer.
I think it's something very interesting that we can do. I think the ctDNA has different scenarios from where that we can use, of course, not just for follow-up, not just to individually design this, to see whether the patient can, to see whether we can predict an early relapse and optimize adjuvant treatment or be more aggressive. I think in the neoadjuvant context, this type of measurements can help us so that during treatment, and if we do this serially, it can give us an idea of whether the patient is responding or not. We've seen this in other trial designs with an EGFR mutation when we use tyrosine kinase inhibitors, and the negativity of the ctDNA is a predictor of good results or good responses. We would have to correlate this, these measurements that we do in the blood with the pathological responses for the surgery in those patients who receive neoadjuvant. So the pathologist and the molecular biologist have to work hand in hand with us now.
And I think there are data from, so as Dr. Garcia mentioned, there are a lot of data from metastatic lung cancer, more so small case series retrospective in early stage disease, suggesting a correlation between tumor DNA response and pathologic complete response, which I had a slide of a couple of anecdotal cases, but there are other groups have done larger studies of 30, 40 patients suggesting the same thing, that PCR at least appears to correlate with clearance of ctDNA, and that was evident in a subset analysis in the Checkmate 816 study as well, which was about 1/4 of all patients we were able to analyze, and they did appear, PCR did appear to correlate with clearance of ctDNA in that group. But I think that highlights one of the difficulties is that, especially in the neoadjuvant setting, if you want to evaluate the ctDNA using a tumor-informed panel, you're trying to do the ctDNA, create the panel by whole exome sequencing, which can take time and and also requires a significant amount of tissue. So perhaps the application may be more in the adjuvant setting. And there is an ongoing study, the Mermaid trial, which is using a tumor-informed ctDNA panel to try and triage patients to adjuvant therapy.
Muchas gracias. Una última pregunta. Quisiera escuchar.
One last question. Now, Dr. Ford, I know you're all experts from a standpoint. Well, a few years we only had adjuvant therapy, and now we had phase 3 adjuvant trials and the study presented by Dr. Ford. Let's say a patient who can be a candidate for surgery and then adjuvants, or include the patient in a neoadjuvant clinical trial from a medical standpoint and the surgeon's vision. Will the patient be lost in neoadjuvants? Could the surgery be more complicated from a technical standpoint? I would like to know your opinion.
Well, my surgical colleagues can comment as well, but the data, at least from Checkmate 816, would not suggest that there was a worsening of outcome in terms of surgical outcomes from adding immunotherapy to chemo. Whether the patients would have had fewer surgical complications if they had not gotten neoadjuvant therapy, probably. But I think so if there is to be a movement towards neoadjuvant therapy, it'll depend on the longer term outcomes, as Dr. Garcia mentioned, the event-free survival, which is the equivalent of disease-free survival in the neoadjuvant setting, and ultimately overall survival. And I think it'll be a long time before we see adjuvant data with chemoimmunotherapy. So if we are to use chemoimmunotherapy in the near future, and by near future I mean probably 5 years, then it will depend on neoadjuvant trials, But I'd be interested to see what Dr. Stiles and Dr. Antonoff feel about the risks of doing neoadjuvant versus adjuvant.
Well, Dr. to let me have the field first, and I'll go. I was just joking with her on the side that I have to debate it and debate 4 neoadjuvant in a week against a medical oncologist rooting for adjuvant. You would think it would be the other way around, because it's certainly probably easier on the surgeon to go the adjuvant pathway. But the Checkmate 816 data was incredibly convincing to me. I think if you look at patients who are going to get neoadjuvant chemotherapy, that suggested that lower rates of pneumonectomy, lower rates of conversion, faster operating times. I think it's as safe, and I think really the response across 1Bs to 3s, the response across PD-L1 subsets really has me convinced that neoadjuvant's the way to go, and we can deliver it in a shorter time period. And I'll let Dr. Antonoff weigh in about the uptake of neoadjuvant, adjuvant, and other things that she's prompted me with.
I think those are great points that you've made, and I totally agree with everything. And I think the only other aspect to consider is the patient experience, aside just from outcomes data in terms of the R0 resection and the extent of pneumonectomy and everything else, but the patient experience overall. We know that even when we talk about standard chemotherapy, we know that patient compliance and completion of receiving all of the intended therapy is better when they have induction therapy rather than adjuvant. And I think that's something we need to think about. And so when we talk about these clinical trials, looking at adjuvant or neoadjuvant, patients are pretty compliant with what they're supposed to be getting on a trial. But in real life, when we translate it to our regular everyday patients, we may have better completion of all intended therapy if we do it in the neoadjuvant setting.
Y yo, para cerrar, quiero.
And just to close, I agree with all my colleagues. The truth is that I am very motivated in neoadjuvants. I think it's going to be a very interesting scenario. However, we still need time. And that time, as I said in my talk, is difficult when you results on the one hand, and you have the patient in front of you, and you carry out those strategies in your patients. That's very complex, but we also have to understand that clinical trials don't reflect the real life. It is a very different scenario to the one we see. I'm not being pessimistic. I these data to mature, but nevertheless, it is an exciting time in lung cancer.
Cáncer de pulmón resecable. Quiero agradecer por sus
panelists for their wonderful presentations. It's a privilege to have you all, and hopefully next year we can meet in person and talk a little bit more about what's going to happen next year. Thank you for your presence. Thank you.
Thank you.